Good morning, all the participants. Can you hear me?
Yes, we can hear.
Yes. Hi.
Yes, you can hear.
36 participants.
I will be taking the screenshot right now. Please open your cameras. First, attendance screenshot. Okay, we are done with our first attendance. To start with, I would like to welcome you all to our CME on heart matters. The concept behind this CME was we are noticing many cardiac issues in youngsters, and as the medical practitioners, we should brush up and update our knowledge for treating our patients with good justice. So the agenda was designed by Dr. Shafi sir, and the topic is Heart Matters: A Holistic Approach to Cardiovascular Disease. With this, I would like to invite the director of Elite CME Academy, Dr. Shafi sir, to kindly welcome you all and give a brief introduction of Elite CME Academy, Jews Indian Institute of Medical Science and Research, and what is the purpose of this program. Uh, all over to Dr. Shafi sir.
A very warm good morning to all of you. Elite Education and Welfare Society welcomes you all to this seventh webinar organized by our academy. We all know that Maharashtra Medical Council has made it compulsory to renew our registration every 5 years. For that, we need some credit points. So, keeping that in our mind, we have decided that we will organize one CPD or webinar every 2 to 3 months. Last December, we had webinar on COVID-19. Now we have this webinar on heart matters, a holistic approach to cardiovascular diseases. Myself, Dr. Mohammed Shafi, professor in the Department of Community Medicine at JIIU's Indian Institute of Medical Science and Research, Badnapur, Jalna. With my team, Dr. Zubair Khazi and Dr. Jawad Hashmi, March 2023, we have started this Elite CMA Academy. Now it is called as Elite Education and Welfare Society. Very soon it is going to be registered with Charity Commissioner, and it will be a accredited organization by Maharashtra Medical Council. So time to time, we are organizing such academic activities, and there are many people who are getting benefited from such activities. I'm thankful to all of you that you have joined and registered this webinar. And also, I'm very thankful to all my friends who just by a message of WhatsApp are ready to be a faculty or resource person for this webinar and also previous webinars. So today we have 7 speakers starting from Dr. Smita Chauhan, Dr. Abhay Mane, Dr. Yogesh Lakkas, Dr. Bhosle sir, Dr. Trupti Gorudkar madam, Dr. Shruti Chandra madam, Dr. Duba Fatima, all are our friends and they are very good and they are very cooperative. Dr. Mahesh Tanade, Professor of Obstetric and Gynecology from our college. So not only from our college, but from all over Maharashtra, we have faculties. They are taking a lot of efforts to make this webinar successful. I am very thankful to them also. I am thankful to our founder chairman, Maulana Ghulam Muhammad Wastanwi Sahab, for starting Indian Institute of Medical Science and Research, and our current chairman, Maulana Huzaifa Wastanwi Sahab, for encouraging and supporting us, and the deriving force and the organizing chairman for this webinar, Dr. Azhar Ahmed Siddiqui, the dean of our institute. I am very thankful to all of these people and also to all the group members of Elite Education Welfare Society. So I welcome you to be present for whole webinar and also be present while we take the screenshot of your attendance, because we have to submit it to the Maharashtra Medical Council. Then only they will grant the points to you. I am very thankful to all the delegates. They have registered, but I think there are many they have not joined the group, because group we put lot of information and guidelines how to attend, and also after the webinar we are putting certificates, your certificates. So and now also registration is open up to 10 o'clock. Those who have not registered, they can also register. You can ask your friends also to join. This webinar is going to be a very good academic feast. So once again, I welcome you all. Now we will proceed for the webinar now onwards. Over to Dr. Zubair Khazi.
Thank you, sir. To start with, I would like to introduce our first speaker, Dr. Smita Santosh Chavan. Madam is professor in community medicine at HBT Medical College and Dr. NCH Mumbai. She is member and contribution in starting the Cooper Hospital. She is additional dean at Seven Hills dedicated COVID hospital Mumbai during 2022, and she has received the Best Teachers Award. She has 42 publications and books on comprehensive management of COVID pandemic. She has also contributed in two books on COVID management, that is by BMC. She have received COVID awards from Honorable Governor, Mumbai Municipal Commissioner, Mumbai Mayor, and various authorities of BMC. She is treasurer of Maharashtra IAPSM, associate editor of IAPH News Shuttle, state coordinator of IPHA Quiz 2024, secretary of MJPJY committee, joint secretary of Staff Research Society, member of Medical Education Unit, and external IEC member at Seven Hills Hospital. She will be talking on the epidemiology of cardiovascular disease. That is the point of main concern. She will be talking about it. So, ma'am, you can start sharing your screen as I stopped sharing mine.
Thank you so much. Am I audible?
Yes, madam, you are audible to me.
Thank you. So, I congratulate Elite Education and Welfare Society for organizing this seventh webinar, as you all said, in succession. And really, it's a very heartful success for you all to arrange such MMC accredited CME points, workshops, and webinars. And I'm very thankful to Dr. Shafi sir. He invited me for this lecture. Thank you so much. As I'm a professor of community medicine in the medical college, I would like to start this session with the epidemiology. Right. So we all know that epidemiology is the study of distribution and occurrence of the disease in relation to various events occurring in the community. And why we study this epidemiology is to apply this knowledge for the control of the particular disease in the community. So we need to understand the trend. We need to understand the disease per se, so that why these things are occurring. And nowadays we are having this non-communicable diseases trend increasing in the developing countries. It was previously thought of the disease of developed countries. Since last few decades, we could see that this trend is rising in developing countries like India, and it is of a major public health concern for all of us. To start with, what includes the cardiovascular disease is it is the group of diseases affecting heart and vascular system. As you can see in this picture, we have different aspects of this cardiovascular disease, which we can classify it as coronary heart disease. That is angina pectoris, myocardial infarction, cardiac failure, sudden deaths, etc. comes under coronary heart disease. Then cerebrovascular accidents and diseases like stroke, transient ischemic attacks. Then we have hypertensive heart diseases, peripheral vascular diseases like deep vein thrombosis and pulmonary embolism. And this infectious disease by the streptococcal infection, we get rheumatic heart diseases, which is common in the developing countries and underdeveloped countries. Still, we are having many cases all over India. Congenital heart diseases having at birth defects of the heart walls or arteriovascular cardiomyopathies. So when we look at the prevalence and incidence of these diseases all over world, we could see that this is the number one cause of death globally. Out of the estimated 17.7 million people died of CVD, it is the we can say that majority, one third of the deaths are because of the cardiovascular diseases, and of these global deaths, 7.4 million deaths were due to the coronary heart disease, and 6.7 million were the stroke. So we can see that this trend is on high level as compared to the other diseases, and also the age specific mortality rate means the deaths in the younger age group. This is the major concern with the low and the middle income countries. 82% of the world's deaths because of the CVDs are occurring in the low and middle income countries. Even if the prevalence of the disease is was more in the developed countries, and it is rising in the developing countries, but when we look at the mortality, it is more in the low and middle. It is so we will see in the further slides. The incidence of CVD is greater in the urban areas than in the rural areas because of the various risk factors and the lifestyle disorders, tobacco consumption, lack of physical activity, unhealthy diets. As we know, nowadays we have fast food, Zomato, Swiggy. They are delivering the food stuff very easily at home. So these are the reasons why it is more in the urban areas. Peculiar cause of concern is the relatively early age of CVD deaths in the developing countries. We nowadays we frequently come to learn many such deaths of our friends in the very early ages, 40s, 50s. We are having a 35 also, or even before that. We are having so many news in the newspaper and the media that yeah, so and so had a heart attack and sudden death in the very early age. So ironically, CVDs are now in the decline in the industrialist countries. They seems to have crossed the peak of epidemic by now, but we are facing this problem, and it is increasing decade by decade. The decline in the is largely is a result of success of primary prevention and to a lesser extent treatment. Prevention, which was implemented in the developed countries, taking into consideration the lifestyle modification and the addictions and unhealthy diet which were noticed, were taken care, and then that was the reason that the decline has started in these developed countries because of the good health education and awareness among the people. So if we see nice pictorial presentation of this bar graph showing that high income countries, and then the compared to the other India and all, the mortality rate in the because of the CVD in the women, we can see in the high income countries it is more comparatively than the males, and where the in India we can see it is more in the male. And age specific standardized CVD mortality rate is more in the male. This is because at the early age, the males are dying more of the cardiovascular diseases because of the different aspects of the risk factors, like the as we have enumerated these risk factors like the tobacco consumption, addictions, obesity, unhealthy diet, and all, and exposure to these risk factors at the early age leads to the early age mortality of because of these cardiovascular diseases. Look at the Indian scenario now. We have 27% of the mortality because of cardiovascular diseases, followed by the communicable diseases and respiratory diseases and other. So this obviously gives us an idea that we are also having the big epidemic of this cardiovascular diseases now, and it will be of the major concern further in the few decades till we have our awareness sessions and health education among the community. The people should understand the severity of this disease and prevention of risk factors. An estimated 2.59 million people died of CVD in India during 2016. India suffers the highest loss in potentially productive years of life due to deaths from CVD in people aged 35 to 64. As I was telling you, the premature deaths, out of the premature deaths, the majority is happening in the low and middle income countries. The prevalence of CVD is reported to be 2 to 3 times higher in the urban population compared to the rural in India also. In one of the study, the prevalence of IHD among adults was estimated 96.7% in the urban compared to the 27.1 in the rural areas. And the contribution of risk factors to the CVD have increased massively since last couple of decades. And these risk factors, as in communicable diseases, we talk about the infectious agents, but in the non-communicable diseases, we talk about the risk factors, and these risk factors plays important role in the occurrence of such diseases in very early ages compared to those natural history of the disease when the such sort of non-communicable disease used to occur in the later age of the life as per the physiological conditions of the body. But because of the risk factors, the occurrence of the disease has come as we noticed in the earlier period of life. The public health significance to this is that the leading cause of mortality in developed countries and a rising tendency in the developing countries because of the civilization, urbanization, migration to the urban areas, and lifestyle modification. A major impact on the life expectancy because of these diseases, and it significantly contributes to the morbidity and death rates in the middle-aged population. Because of that, we lose the potential life years, common cause of the premature death, and we have the quality of life deteriorating because of these elements when it comes to the day-to-day activity, and then the overall burden on the family for if some of the uh, person in the early life or the head of the family in its early life getting such diseases will hamper the family life. With this graph, we can see that the age standardized or the age specific rates of the mortality in the men, and similarly in the women here, we can see that the 25 to 64 years we are having the more than 30% of the mortality rates, and it is also now the over a period of 1 decade it has increased a lot. This is a nice Indian scenario where we can see that different states, which the Maharashtra, when we see that cardiovascular diseases in the Maharashtra, we are having moderate to high level of prevalence of the cardiovascular diseases and the ischemic heart diseases. Rheumatic heart diseases are there more in the eastern and northeastern states. But the we can see here Punjab and these states uh, are having equally the higher cardiovascular diseases, ischemic heart diseases, rheumatic heart diseases. So this is the scenario where we can see at one glance the different states having the prevalence rates of these cardiovascular diseases. Why we are more concerned with the mortality issues of cardiovascular diseases? It is all because we are having sudden deaths of our relatives, our friends. We can see our faculties also getting these issues, and then we hear such news among our friends that there is a sudden death of so and so. This is happening, and 20 to 70% of the coronary deaths and small fraction of the stroke deaths are happening very early in the age. We know that elderly, yes, it was there because of the comorbid conditions the elderly people were having, and cardiovascular diseases was more prevalent previously. But comorbidities and severe mortality and underestimation of the mortality is due to the elderly deaths are classified as non-specific causes, and sometimes the death certification also matters a lot when we give the cause of death for such elderly deaths. This picture shows you the different risk factors for the cardiovascular diseases, like the lifestyle which we have, like alcohol consumption if it is there, tobacco consumption is there, addictions, inadequate intake of the fruits and vegetables, and physical inactivity. These are the lifestyle related risk factors leading to the obesity. We should be concerned with the body mass index, waist circumference, elevated blood pressure, for which we need the monitoring of our blood pressure or tracking of the blood pressure. Then biochemical parameters, lipids, total cholesterol, HDL cholesterol, triglycerides should be of concern for us. And then most important is our diabetes blood glucose level monitoring. Why we are concerned with these risk factors so and so much? Because the present mortality rates are the consequences of the previous exposure to the behavioral risk factors, such as it starts with the period of childhood and adolescence, inappropriate nutrition, insufficient physical activities, and increased tobacco consumption if it is. It leads to the lifetime effect of risk factors for the cardiovascular diseases. It starts very early in the life. I would say starts with the intrauterine life itself. The overweight, central obesity, high blood pressure, dyslipidemia, diabetes, and low cardiovascular respiratory fitness are among the biological factors contributing principally to increased risk. Persistently high cholesterol level can almost certainly precipitate a cardiac events. Unhealthy dietary practices include high consumption of saturated fats, salt, and refined carbohydrates, as well as low consumption of vegetable and fruits. And these tends to cluster together and having the effect on this cardiovascular fitness. Cessation of tobacco use, reduction of salt in diet, consumption of the fruits and vegetables, regular physical activity, and avoiding harmful use of alcohol have shown to reduce the risk of cardiovascular diseases. And these, since many decades, the risk factor trials are going on. The biggest study was Framingham Heart Study, which was started in the city of Framingham in the year 1948, and it is still in continuation. They are tracking these patients. To start with, there were 5,209 patients enrolled in those in this Framingham Heart Study, and over a period of these many decades, accessible and affordable health services available at all the time. There are a number of underlying determinants of these cardiovascular diseases, which are reflections of the major forces driving the social, economic, cultural changes. Forces driving the social, economic, cultural changes. We have globalization, urbanization, and population aging, which are the important factors in the occurrence of cardiovascular diseases in the community. Other determinants are also important, like poverty, stress, and hereditary factors. These are also major contributing factors in the occurrence of these diseases. We have non-modifiable risk factors and modifiable risk factors. Non-modifiable, we really can't do much about these non-modifiable risk factors, like age. For higher ages, blood pressure rises with age in both the sexes, and tracking phenomena is exhibited. Represents the accumulation of the environmental influences and genetically programmed senses in the body system. No early life differences in the male and female, but higher levels starting from the adolescents. Most prominent differences in the young and middle age adults. Differences narrows in the later life. Then genetics, we all know that it is if it runs in the family, then there are higher chances of getting this disease. Then ethnicity is also playing important role. uh, we are more concerned with the modifiable risk factor, because these are the factors which we can do something about. That obesity, central obesity with a high waist hip ratio predictive of the hypertension, direct relationship with the weight gain, decreases with the weight reduction. So we all are aware of these factors, and we accordingly we should advise to our patients. Then about the salt intake, high salt intake, if it is 7 to 8 grams per day, increases the blood pressure proportionately. Example can be of the Japan versus the primitive societies. Potassium intake lowers the blood pressure. So accordingly, we need to advise our patients. And we all know that smoking and tobacco are directly related to the occurrence of the disease. Then saturated fats to be avoided. Dietary fibers are important to be included in our day-to-day diet. Physical activity is very important. Heart rate reflects resetting of the sympathetic system to a higher level, increases the blood pressure. Then psychosocial and environmental stress, it also increases the blood pressure. Oral contraceptive agents, if any, it also increases blood pressure due to estrogen. Then socioeconomic status. In the post-transitional societies, more prevalent among the lower socioeconomic groups. In transitional and pre-transitional ones among the upper strata. So now in the India is having the intermediate situation where we have communicable diseases also, and non-communicable diseases are also in the increasing trend. This one is very important, rheumatic heart diseases. But in this, the death certification and accurate diagnosis, these are the limitations for our country. In developing countries, RHD is important and underreporting cause of the death. Majority of RHD's death occur before the fifth decade. In developed countries, this is a rare cause of death. But because of the misclassification of the cause of sudden death, RHD, comorbidities, and aging is an obstacle to understanding the cardiovascular rates and trends. So, for accurate diagnosis, trained personnel and adequate resources are required. Hypertension, as we all are aware of this is widely prevalent and commonest cardiovascular disorder, posing a major challenge to the population in socioeconomic and epidemiological transition like India. So it accounts for 20 to 50% of all deaths, and it has played a major role in the coronary heart diseases, stroke, renal diseases, and retinopathy. So hypertension is very important concern for us, for which we need to have the blood pressure measurements, and we need to see whether it is in which type of the category of the hypertension. Pre-hypertensive, we can say up to the 140 of systolic and 90 of the diastolic, but hypertension more than 140, 90, and severe stage of hypertension more than 160, 100, this needs the emergency care for the patients, and reduction of the blood pressure is very important to prevent further complications. There can be the isolated systolic hypertension more than 140 millimeter Hg, or isolated diastolic hypertension more than 90 millimeter of Hg, which is also of a major concern. How to prevent these cardiovascular diseases? When we are aware of the risk factors, when we are aware of the pathophysiological things, and some of the things which modifiable risk factors, we can prevent these risk factors. We can target the entire population for the same. We can have the individual one-to-one intervention for the person, but population strategies for such cardiovascular diseases have impact on the society uh, through the primary prevention, then secondary and tertiary prevention. So in primary prevention, in population strategy, when we talk about that, it is directly related to the whole population irrespective of the individual risk factor. The concept is that even a small reduction in the average blood pressure of a population would produce a large reduction in the incidence of cardiovascular complications such as stroke and coronary heart disease. So community intervention is very, very important in the cardiovascular diseases. It is to shift the community distribution of the blood pressure towards the lower levels or biological normality. So we need to implement the multifactorial approach. Like the most important is the nutrition. So I would elaborately talk about the nutrition in this topic because it is a modifiable risk factor, and it is the topic of the health education and awareness. We need to talk about this to our patients, to our friends, to our relatives, our community. So reduction in the intake of salt intake to no more than 5 milligram per day. So salty items like pickles, dried fish, bakery items, papad, smoked and salted and cured food, Chinese food need to be, lessened or the reduced, or it should be avoided. Moderate fat intake, avoid fatty dairy products, cream, fried items, sweets, potatoes, root and tubers, rice and red meat. Especially those are already had acquired these risk factors, we need to advise them accordingly. Consume food containing mono and polyunsaturated fatty acids like boiled fish, almonds, etc. Then high fiber intake like fresh fruits, vegetables. These contain the potassium, contain the minerals and vitamins, antioxidants, which are very much advisable. It should be the awareness right from the childhood itself. So the good lifestyle should be inculcated in the child, so that when they grow to the adult and the later age, they will not face such problems. Avoidance of the high alcohol intake. No amount of alcohol is advisable ideally. So alcohol should be very less or should be avoided completely. Then exercise promotion, moderate intensity, aerobic physical exercise for 30 minutes on most of the days is the recommended thing. Weight reduction, we need to keep our BMI between 18.5 to 24.9 kg per meter square, which is well aware. Health education sessions for those at the high risk and also in the community, and we need to tell them about the self monitoring and care. We know means I mean every Sunday, today is a Sunday, every Sunday how many of us monitor our blood pressure and weight when we are at home? At least keep a diary, write down your weight, write down your blood pressure. uh, how many of us do? Even if we doctors we do not follow, how can we advise to the others? So self monitoring and care is very important in terms of the screening of these non communicable diseases for us. That is the only tool which can be used to keep check on such occurrence of the risk factors and the diseases. Behavioral modification like stress reduction, smoking cessation, lifestyle modification, yoga, pranayam, meditation. These are all advisable, recommended things which everybody is aware. But then we need to take out the time for all such behavioral modification, which is really possible for each and everyone, which should be followed uh, actually. So high risk strategies is one aspect where we need to aim to attain the level of blood pressure at which the institution of the treatment would be considered. So we need to prevent the such risk factors, such occurrence of the hypertension in the person. It is the considered appropriate if risk factor prevalence in the community is low. Detection of the high risk individuals should be arranged by the optimum use of clinical methods. As hypertension clusters in the families, tracking of blood pressure from the childhood may be used to identify individuals at risk. So it runs in the family. So other family members should be cautious enough to monitor their blood pressure and other risk factors. Secondary prevention, yes. In secondary prevention, we say that early diagnosis and treatment is very important. So to detect, control high blood pressure in affected individuals and prevent complications with the modern antihypertensive drugs is important. Early case detection for the high blood pressure, and because it rarely causes any symptoms. The blood pressure is high, but we may or may not get any signs and symptoms out of that. So screening linked to the treatment, follow up and sustained care is the recommended thing. Screening camps may be held for the high risk groups and treatment with the antihypertensives like that. So you have to seek treatment from the physician if you are getting identified with the high blood pressure, and then if you have some sort of signs and symptoms of the ischemic heart disease, then we need to start all these medications. And then patient compliance is very very important for that. The patient compliance is that extent to which the patient's behavior in terms of taking medicine, following diets, and executing other lifestyle changes coincides with the clinical prescription. It presents a problem as hypertension is a lifelong condition. The patient starts feeling better, they leave the treatment, they will not take the medications, and one fine day they will have the high grade of hypertension with the signs and symptoms of the strokes or other complications. So they'll end up very badly in these complications. So it improves with the health education to the family, patient family, and the community. We need to focus not only on the patient but also in the family and the community. And there is also a need to strengthen the existing health infrastructure to better deliver these interventions to the community and benefit the country. So we have now the under the national program of non-communicable diseases, they have created the NCD non-communicable diseases corners in all the hospitals or all the dispensaries, health post and primary healthcare level. Now the health and wellness centers have been developed in the sub center wise, and then there is a community health officer which goes into the community and takes the blood pressure and screening of non-communicable diseases. The government is implementing this non-communicable diseases program nicely, but as a doctor we also need to support this program through our patients. This was all about the epidemiology. It is a topic of concern for all of us, which need to be addressed properly. So we all are aware about the risk factors and the complications of this. But sensitizing the community, sensitizing the patient and family is very important. This is from my side. If you have any questions, we can discuss, or we can have. If you have any case, we can discuss accordingly.
Madam, you can stop sharing your screen.
That's what I was searching about. Okay, stop share. Yes.
Thank you very much, madam. Definitely, Madam has highlighted many factors, and also for us, that is doctors, the Sunday plan of the Madam, we will definitely promote your vision of the Sunday program for doctors, that every doctor should check blood pressure and various vitals on Sunday for himself, and then we should advise to patients, because cardiovascular diseases are definitely increasing in healthcare professionals also. I request Dr. Shafi sir to kindly present memento to Smita madam. Madam, this memento will reach you very soon. So please accept the memento here.
Thank you, sir.
Yes, madam. Thank you.
It's a nice gesture, sir. Thank you so much. And I could see, I think, more than 60 participants. I really congratulate, sir. I mean, really wonderful program, and I am very happy to contribute in that. Thank you so much for it.
Thank you. Thank you, ma'am.
Thank you.
Thank you very much, madam. You can mute your audio now. Our next speaker is a very dynamic lady, Dr. Shruti Chandra, madam. Madam is currently working as associate professor in MGM Medical College, Chhatrapati Sambhajinagar, Aurangabad, Maharashtra. She has perceived her graduation from King's George University, that is in Lucknow, and she has also received two gold medals during her UG level, and one silver medal and certificate of honor in 14 subjects of her graduation. She has passed her MD pharmacology from GSVM Medical College, Kanpur, with honors. She has also completed the certificate course in diabetes mellitus management and a fellowship in family medicine. She is working in field of academics from last 10 years. She also worked as medical advisor at IPCA Laboratories, Mumbai, in international division. She has attended many conferences, has published around 20 papers in Index Journal. She has contributed in three books chapter. She has served as speaker, moderator, judge, and in many national conferences. She has received Young Researchers Award by Institute of Scholars, Bangalore, Karnataka in 2023. She has won Merck Ceron Award for Best Oral Paper Presentation in Scientific Session on Cardiovascular Sciences in EPSICON 2011. She has received Ahilyabai Holkar Adarsh Shikshak Puruskar at Bid, Maharashtra in 2012. She is a life member of IPS, Indian Medical Association, National Association of Pharmacology and Therapeutics, and Medical Pharmacologist Society. She is a member of Research Cell and Curriculum Committee at MGM Medical College. She has a wide experience in field of research, academics, pharmacovigilance, prescription audit, clinical trials, medico writing, medico marketing, medical writing, and many more. You will definitely find all these things during the madam's talk. So I stop sharing my screen and request madam to kindly share her screen.
Okay, I'll share now.
Yes, madam, you are audible. Your screen is visible, madam.
Okay, nice. So thank you, Dr. Zubair, for such a nice and detailed introduction. Good morning, everyone. Should I start?
Yes, madam.
So the topic given to me is cardiovascular pharmacology. That are the drugs used in cardiovascular system. So as you all know that this is not a 30-minute talk, but this is a lectures. These are the lecture series for at least 10 to 12 lectures, which goes on for 1 month. So I'll try to touch according to the diseases and main classes of the drugs and what are the importance of those drugs. So, as we all know, that cardiovascular diseases are the leading causes of death globally, taking an estimated 17.9 million lives each year recently. So, most common encountered cardiovascular disorders are hypertension, congestive heart failure, angina pectoris, cardiac arrhythmias, and others. So, these are the drugs, they have major action on heart or blood vessels, or those primarily for cardiovascular disorders are designated as cardiovascular drugs. So I'll be covering this topic briefly, the drugs which are used for hypertension, the drugs for heart failure, angina pectoris, and antiarrhythmic, and also some of the recent advances which are coming in the field of the drugs. So starting with the hypertension, this is the most common cardiovascular disease and definition and classification is beautifully covered by Smita madam. So I will not take this. Also, non-pharmacological approaches are in detail covered by Madam. She has also already explained that how the weight should be monitored, how the exercise should be done. So I will be focusing on pharmacological therapy. So mostly patients require pharmacological therapy when they suffer from one or other cardiovascular disease. So for hypertension, we have a big class of drugs. So at least 10 to 15 classes of drugs which are used in some or other types of hypertension. So this is the classification of antihypertensive drugs. So I'll be taking each class some of the drugs and importance of the drugs. So basically we have a full class of diuretics, then drugs who are acting on RAS system, which is renin angiotensin system. Then we have sympathetic inhibitors, in which include alpha and beta blockers, and then central sympatholytics. So, if you see various guidelines which are covering these diseases treatment, like American Heart Association or Joint National Committee or European Heart Association, they are updating these guidelines years. So earlier they have given the first line drugs and second line drugs. So although these guidelines are mostly applicable to whole population, but in Indian scenario, sometimes the drugs which are not there in first line, we are also using them. So I'll like to brief them. So first and foremost class, which is very important, which is used in cardiovascular system is ACE inhibitors, which is angiotensin converting enzyme inhibitors. So these include enalapril, ramipril, lisinopril, perindopril, fosinopril, quinapril, tenolapril, imidapril, benzapril, and so on. So we have a big number of drugs. So these drugs basically inhibit ACE enzyme, preventing the conversion of angiotensin 1 to angiotensin 2. So which has various actions like decrease in vasoconstriction and aldosterone secretion, which reduce ultimately systemic vascular resistance and sodium and water retention. Also, it increases the bradykinin level, leading to vasodilation. So that is the reason why ACE inhibitor causes dry cough. So this is the same which I have explained in the form of a pictorial diagram, that mainly the action is of angiotensin 1, and these actions are inhibited by ACE inhibitor by stopping the enzyme ACE. So these drugs are indicated in hypertension and other comorbidities. Basically, if somebody is suffering from heart disease along with diabetes mellitus, then ACE inhibitor becomes the first choice because it prevents the diabetic nephropathy. Also, this is used in chronic kidney disease and it provides renal protection. ACE inhibitors are also indicated in heart failure with reduced ejection fraction. It causes remodeling, it prevents the remodeling of the heart, and also it has long term effect in terms of genetic modifications. So, that is why the morbidity which is cardiovascular patients are suffering is reduced by ACE inhibitors. Then these are also given in post myocardial infarction for the same reason. Then prophylaxis in high risk patients, ACE inhibitors are used, and also scleroderma crisis. Common adverse effects of ACE inhibitors are dry cough, because of which sometimes you need to change the drug due to bradykinin levels. Then hyperkalemia, so we need to monitor the potassium level. Then angioedema is rare, but serious side effect is if it occurs. Then rashes, urticaria, and dysgeusia, which is distortion of the taste. Then sometimes hypotension, which is especially after first dose. That is why we called it as first dose effect. This drug is particularly contraindicated in pregnancy because this causes fetal growth retardation and hypoplasia. So, other drugs are given if a pregnant lady suffers from cardiovascular disease. The next class of the drug is angiotensin receptor blocker, which include losartan, valsartan, candesartan, telmisartan, olmesartan, irbesartan, and so on. So, this blocks angiotensin 2 receptors, particularly 81 subtype, preventing the vasoconstriction and aldosterone effects which we have just seen, and it has no effect on bradykinin metabolism. That is why it doesn't cause that much cough. Preferred alternative for patients who are intolerant to ACE inhibitor. So somebody, if he is not tolerating ACE inhibitor, then we give ARBs for the that particular patient. The indications are same as ACE inhibitors, which we have just discussed. And common areas of this class are hyperkalemia, hypertension, and angioedema, which is a rare adverse effect. Then another group which is commonly used in hypertension is thiazide diuretics, which includes hydrochlorothiazide, chlorthalidone, indapamide, and other drugs. So these drugs basically inhibit sodium chloride importer in DCT and increases sodium and water excretion, reducing the plasma volume and cardiac output. So long term, they basically decrease the systemic vascular resistance through vasodilation. That is why they are also a preferred class in treatment of hypertension. Although the other diuretics are not used in hypertension preferably, but they are used in other edematous conditions according to their potency. So indications of thiazides are mild to moderate hypertension, and this is effective in salt sensitive hypertension, especially in elderly African American patients. They are used in combination therapy with other antihypertensives. The main adverse events are electrolyte disbalances like hypokalemia and hyponatremia, and hyperglycemia and hyperuricemia is also seen with this class. Then there are certain second line agents according to the guidelines in which they have included beta blockers, but I would like to emphasize that in Indian scenario we are using beta blockers many times as a first line drug because in India the patients are responding effectively to beta blockers, and this is suitable to many patients. So that is why it includes metoprolol, atenolol, carvedilol, bisoprolol, and other drugs. So here they block beta adrenergic receptors, which is beta 1, and they reduce the sympathetic activity. So decrease heart rate, cardiac output, and renin release from kidney is main mechanism how they work. They are indicated in post MI. They also reduce mortality, and morbidity is also in control. Heart failure with reduced ejection fraction, where it improves the outcomes. Then arrhythmias are the main also indication of beta blockers, and then hypertension with angina. So basically here we are using among all beta blockers in cardiovascular system, we are using cardioselective beta blockers because they minimize the bronchospasm risk. So they can also be used in patients of asthma and diabetes because they are not masking the symptoms of hypoglycemia, and they can be given in asthma patients also. And carvedilol is used if combined alpha and beta blockage effect is required. Main adverse events of beta blockers are bradycardia, fatigue, cold extremities, bronchospasm for especially non-selective, mask hypoglycemia in diabetic patients, and erectile dysfunction with non-selective. Next class of drug is vasodilators, so which include hydralazine and dihydrolazine. They are directly acting arterial vasodilators with little action on venous capacitance vessel, so they reduces TPR. Adverse events are basically due to vasodilation, that is facial flushing, conjunctival injection, throbbing headache, dizziness, palpitations, nasal stiffness, fluid retention, and edema. They are the drugs which are used in moderate to severe hypertensive patients. Hydrolysine can be used in patients with renal involvements, and the arterial dilator action of hydrolysine is used in the management of congestive heart failure also. Another class is aldosterone antagonist. So these include spironolactone and epinephrine. So it inhibits the aldosterone action in DCT and collecting ducts, promoting the sodium excretion and potassium retention. They are indicated basically in resistant hypertension, where theirs are effective in patients of hyperaldosteronism or secondary causes. This is also given in heart failure with reduced ejection fraction, where they reduce mortality. And also, they are used in edematous conditions. The ADRs are hyperkalemia. So, you need to monitor the potassium levels, especially in patients of kidney diseases, and they may also cause gynecomastia and menstrual irregularities. So, that's why these are the drugs sometimes combined with drugs who are causing hypokalemia to counteract the effect on potassium levels. Then, direct renin inhibitors, which is elastrin. So it inhibits the renin activity, reducing the conversion of angiotensin to angiotensin 1, which blocks entire RAS cascade at initial step. So they are used in reducing the blood pressure. But long-term CV benefits are not well established till date. So they may be combined with other agents when traditional first line are not working properly. So adverse events are basically diarrhea, hyperkalemia, and they are also contraindicated in pregnancy. The next class, which are mainly used, is central sympatholytics, which include clonidine and methyl dopa. So both these drugs have different properties. These are partial agonists with high affinity and high intrinsic activity at alpha 2 receptors. Adverse events are basically sedation, mental depression, disturbed sleep, dryness of mouth, nose and eyes, impotence, salt and water retention, bradycardia. So clonidine is basically used in opioid withdrawal, alcohol, and smoking cessation. An antihypertensive drug is methyl dopa, which is used in pregnancy. So this is a slide which says that when your patient is suffering from different comorbidities, preferably which drug should be chosen. So diabetes mellitus, the dictum is ACE inhibitors. If it is not tolerated, then angiotensin receptor blockers. Chronic kidney disease, ACE inhibitors or ARB, because it affects proteinuria, it decreases the proteinuria. Heart failure with reduced ejection fraction, ACE inhibitors, ARB, and beta blockers, they reduce mortality. Also, they act on cardiac remodeling. That's why, in long term, they are effective in working the heart properly. Elderly with isolated systolic hypertension, the drug of choice is calcium channel blocker, that is amlodipine. African American population, usually thiazides are preferred, and post MI, beta blockers, and ACE inhibitor for the same reason they work on cardiac structure and prevent remodeling. In certain special scenarios in hypertension, like hypertensive emergency, the drugs here, this is the severe elevation in blood pressure, that is 180 by 120 millimeter of Hg. So this is accompanied by acute target organ damage. So here we use sodium nitroprusside, labetalol, and nicardipine. Sodium nitroprusside is a direct vasodilator which releases nitric oxide to reduce both preload and afterload. Labetalol is a combined alpha and beta blocker, reduce systemic vascular resistance and heart rate. And nicardipine is given, it is a dihydropyridine calcium channel blocker. It's important arteriolar vasodilator. If a pregnant lady is suffering from hypertension, so I already said that ACE inhibitors and ARBs cannot be used in this case. So preferably we are using methyl dopa, labetalol, and nifedipine. So the mechanism is same and they are indicated in pregnant lady with hypertension. So I would like to emphasize some new drugs. Actually, in today's scenario, these are not new. Many doctors are already using. So these are the class of drugs which are coming in the cardiovascular system, like SGLT2 inhibitors. So detail of these drugs will be given to you by our next eminent speaker. This is Dr. Ghosle. Sodium glucose co-transport 2 inhibitors like empagliflozin, dapagliflozin, canagliflozin. These are primarily approved for diabetes management and they lower the blood pressure by inducing osmotic diuresis and reducing the arterial stiffness. So they give cardiovascular and renal protective effects, making them promising in hypertension, especially in patients with diabetes and chronic kidney disease. So currently they are approved for diabetes and heart failure with reduced ejection fraction. So there is EMPA kidney trial of empagliflozin, which is there for CKD and BP control. Another class, novel class, is mineralocorticoid receptor antagonist, which is isaxarenone and finerenone. So this blocks aldosterone effects on sodium retention and vascular remodeling, and more selective than traditional agents like spironolactone. They minimize the side effect like gynecomastia. Diphenhydramine has demonstrated cardiovascular and renal protection in FIGARO-DKD and FIGARO-DKD trials. So it is currently approved for diabetic nephropathy. Then another class is endothelin receptor antagonist, which is aprocitentan. So this blocks endothelin receptors ETA and ETB to prevent vasoconstriction and vascular hypertrophy. So this is studied in resistant hypertension and currently it shows promises for long-term blood pressure control. Then we have dual angiotensin 2 receptor and neprilysin inhibitors. So this is, I think everybody knows this combination, sacubitril and valsartan combination, which is approved for heart failure patients. So this is also shows promises for hypertension. This has combined action, so it blocks ACE, angiotensin 2 receptors, and also neprilysin. So it basically inhibit increased natriuretic peptides and vasodilation. So sacubitril valsartan is already approved for heart failure with reduced ejection fraction and also under investigation for hypertension. So there are trials which are going for this drug and we are currently using this combination for heart failure. So this is all about antihypertensives. These are the main classes which are used for hypertension. So we teach our students like these are A, B, C, D. So ACE, then beta blockers, calcium channel blockers, and diuretics, and others. So now I would like to move to the drugs which are used in heart failure. So this is a clinical syndrome that develops when heart cannot maintain adequate output or can do so only at the expense of elevated ventricular filling pressure. So the classes are basically used to reduce the preload or afterload. So reduction of load is by diuretics, ACE inhibitors, vasodilators, beta blockers, natriuretic peptides, and vasopeptidase inhibitors. Then we use certain inotropes like cardioglycosides, beta agonists, PDE inhibitors, and calcium sensitizers. So here, most of the drugs have already covered with hypertension, so they are also used in heart failure. So cardiac glycosides, the mechanism is increase in the intracellular calcium by inhibiting the sodium potassium ATPase pump, resulting in increased contractility. So this drug is used in cases of heart failure, although today's world we have other drugs. So these are not used mostly. These are the reserve drugs which are used. So adverse effects of this class is bradycardia, heart blocks, GI is nausea, vomiting, anorexia, abdominal pain. Then there are certain psychiatric adverse effects. And also it may cause yellow or white vision, transient amblyopia, or scotomas. Also, they may cause gynecomastia. So they are basically used in congestive heart failure with atrial fibrillation and congestive heart failure with refractory to ACE inhibitors or beta blockers. They are using cardiac glycosides. Then another class which is used in heart failure is phosphodiesterase inhibitors. They are inamrinone and milrinone. The mechanism is they cause inhibition of phosphodiesterase 3, which causes increase in cyclic AMP and causes positive inotropism and vasodilation. That is why this class of drug is called inodilators. So these are used by IV routes and these are used for short-term support of patients with severe heart failure due to systolic dysfunction. Then another class is natriuretic peptide, which is niseritide. So this is recombinant human brain natriuretic peptide, which is BNP. And this is secreted by ventricular myocytes in response to stretch. So they possess the vasodilator, natriuretic, and diuretic properties. So these are used for dyspnea due to congestive cardiac failure, and the problems are fetal renal damage and hypertension. Another class here is vasopeptidase inhibitor, which is omapetrolate. So the mechanism is vasopeptidase is ACE plus NEP, which is neutral endopeptidases. So neutral antipeptidases metabolize both ANP and BNP. So they increase peptides plus angiotensin 2 causes vasodilation and natriuresis. So this drug causes both vasodilation and natriuresis, and the adverse effects mainly are angioedema, cough, hypertension, and dizziness. So there are certain new targets for congestive heart failure. So here a calcium sensitizer, which is levosimendan, which is a calcium sensitizer and inodilator. It augments the cardiac contractility without increasing myocardial oxygen demand or exacerbating the ischemia. Then we have empagliflozin and canagliflozin, which is very much used in cardiovascular disorders nowadays, which increase the excretion of glucose by the kidney and improved overall and particularly heart failure and related outcomes. Then we have finerenone, which is to reduce the risk of kidney function declines and kidney failure, cardiovascular deaths, non-fatal heart attacks, and hospitalization for heart failure in adults. This drug is specially used. Then we have sacubitril valsartan combination, which I have already explained. So this is approved for chronic heart failure with reduced ejection fraction. Another new class of drug in heart failure is vericiguat, which is a soluble guanylate cyclase stimulator. So this augments cyclic GMP levels by addressing the impaired nitric oxide and SCA GMP pathway, which is important in the pathophysiology of heart failure. Then we have ivabradine, which decreases the spontaneous pacemaker activity of the sinoatrial node by selecting inhibiting the IF current to slow the heart rate. So basically, it blocks the pacemaker activity and ultimately it helps in outcomes in heart failure. Then we will move towards the drugs which are used in angina pectoris. So the primary cause of angina pectoris is imbalance between oxygen requirement of the heart and oxygen supplied to it via the coronaries. So these are the classes which are used in anti-anginals. So nitrates, beta blockers, calcium channel blockers, potassium channel openers, and other drugs. So I will not cover here the drugs which I've already covered. So nitrates are the main drugs which are used in angina. So the mechanism of action is peripheral vasodilation and increased coronary flow by releasing the nitric oxide, which ultimately works on the cyclic GMP and causes the vasodilation. So indications are all types of angina, acute myocardial infarction, and congestive heart failure. Adverse events of nitrates are basically due to property of vasodilation, which may cause orthostatic hypotension or tachycardia. Severe throbbing headache is also because of vasodilation in the circle of Willis and dizziness, flushing, syncope. Tolerance is especially important with the use of nitrates, which is also called as Monday disease. That once a patient is working in a factory where nitrates are manufactured, when they go to the company to on Monday, they have headaches because there is vasoconstriction in the cerebral vessels. So that is why they feel good on they feel bad on Monday. Then there is dependence and methemoglobinemia as adverse effects of nitrates. The next class is calcium channel blockers, which act on L type of calcium channel to inhibit the calcium entry. I hope everybody knows these drugs and everybody is using. So amlodipine is used especially in elderly antihypertensive. Also, they have multiple other uses. So increase coronary blood flow, decrease afterload, and decrease oxygen demand. Then it also gives negative inotropic and chronotropic effect. Adverse effects of calcium channel blockers are basically excess vasodilation, which causes dizziness, headache, flushing, peripheral and pulmonary edema. Also, sometimes it may cause cardiac depression, which may lead to various kinds of problems. Next class is potassium channel openers, which is nicorandil, which is an anti-anginal agent. So this relaxes coronary vascular smooth muscles by stimulating guanylate cyclase and increased cyclic GMP. So these causes activation of potassium channel and hyperpolarization. So other drug here is trimetazidine. So trimetazidine is also an anti-anginal drug which inhibit long-chain 3-keto-acyl coenzyme thiolase, which is a final enzyme in free fatty acid beta oxidation pathway, which leads to partial shift from free fatty acid to glucose oxidation in heart, which provides less ATP but requires less oxygen demand, and therefore it is used in ischemic patients. So there are certain new targets which are used in angina. The first is Ranolazine. So this is a second line agent used in chronic angina. It inhibits late phases of inward sodium channel in the patients of angina. Then we have ivabradine, which is used in stable angina and heart failures, where beta blockers are not tolerated. Then there are certain trials which shows promising effect of colchicine due to an anti-inflammatory effect in coronary artery disease and heart attack and stroke. So it has been shown that reducing inflammation provides long-term benefits in patients of cardiovascular patients. Then another drug which is coming up is semaglutide. So semaglutide injections are new indication to reduce the risk of cardiovascular death, heart attacks, and stroke in adults with cardiovascular diseases, either if they are suffering with obesity or overweight. Then anti-arrhythmic drugs. So I will just touch upon the drugs classes which are used for various kinds of arrhythmia. So we classify this antiarrhythmic drugs to prevent or treat irregularities of cardiac rhythm. So we have four classes of drug. Class one is membrane stabilizing agent. So we have A, B, C. So first blocks sodium channel and prolong the action potential, which includes quinidine, isopyramide, and procainamide. Then B blocks sodium channel and shorten the action potential, which include lidocaine and mexiladine. Block sodium channel with no effect on action potential is flecainamide and propafenone. Then we have class 2, which is beta blockers, includes atenolol, bisoprolol, and so on. Then class 3 is drugs whose main effect is prolong the action potential, like amiodarone and sotalol. Then class 4 is nothing but the slow calcium channel blockers, which include verapamil and diltiazem. So newer targets which are used for antiarrhythmics are TASK1 channel blockers, which is tandem pore domain acid sensitive potassium channels. They are recently atrial selective targets for potential rhythm control therapy is TASK1, which includes varnacalant and amiodarone, which inhibits the TASK channels, and doxapram is a selective TASK1 blocker, which is strong antiarrhythmic property. Then we have calcium MK2 inhibitors, which is calcium calmodulin dependent protein kinase 2. So these are targets multiple effector proteins, including ryanodine receptors. So the drug here is rimacalib, which is in preclinical development, which promise efficacy for atrial arrhythmias. So to conclude, this is again, I would like to say this is a broad chapter. The drugs each and every day have different properties. So you have to understand with which drugs are used in which cardiovascular disorders. So I would like to conclude with that pharmacological therapy is a vital component in the management of many cardiovascular diseases, along with non-pharmacological management. So knowledge of mechanism of action is helpful in understanding which treatment option may be best for an individual patient. So you have to individualize along with the comorbidities which are present with cardiovascular patients, and then you have to select the best class of drug for your patient. So choosing the appropriate dose and route while taking into account clinical significant adverse events and drug interactions is also important. So it may be a possibility that one drug class is best suited for one condition, but the patient is not tolerating that drug. So you have to change accordingly as you have to individualize your patient and then choose the class. Most cardiovascular drug therapies by national and international guidelines like American Heart Association, Joint National Committee guideline, and European Heart Association. So as I have earlier emphasized that many drugs they are there in the guidelines as second line or third line drugs, but sometimes in Indian scenario you have to use them as a first line agent because they are most suitable for your patients. So pharmacological interventions are often complementary to non-pharmacological ones. So optimal patient outcomes are achieved with timely initiation of both. So this is basically a combination of non-pharmacological and pharmacological management. Your patient will respond best. One cannot say that I will have only 5 drugs, 6 drugs, I will not exercise, I will continue smoking or alcohol, and then I'll get the good outcomes. So this is a combination of both. You have to counsel your patient, choose wisely, and then your patient will respond good and maintain a healthy life. So thank you so much for your patient listening. So I would like to take any questions if they are there. And also, I will take this opportunity to thank the organizers for giving me this opportunity to give this vast full system to cover in 30-40 minutes.
Thank you, madam. Thank you very much. Indeed, it was a very vast and elaborated section of today's CME, and most important one. But I would say, and I would thank you that you have definitely done the justice to the topic. Madam, you can stop sharing your screen.
Okay.
So I would like to request Dr. Shafi sir to present the memento and certificate to you, and it will definitely reach you tomorrow morning. I will be handing over it to you. So I request Shafi sir to kindly present memento to madam.
Thank you very much, madam, for your excellent talk.
Thank you, sir. Thank you so much.
So with this, we have our respected Ashwamedh Balasaheb Jagtap sir, the MMC observer appointed by MMC with us. I would request Dr. Shafi sir to kindly introduce our your observer, Dr. Ashwamedh Balasaheb Jagtap sir. All to Shafi sir.
I would like to welcome our Maharashtra Medical Council observer, Dr. Ashwamedh Balasaheb Jagtap sir. He is the man of tuberculosis from Jarna. He is the graduate from Aurangabad Medical College and also diploma in public health, a pure public health person working in the field of public health in Jalna district. Dr. Jagtap is known to everyone who are there in the Jalna district. You can see that he is the person with award from the Honorable Chief Minister and the Honorable Governor for his work in the field of tuberculosis in Jalna district. He is a man behind the TB Mukt Panchayat Abhiyan in Jalna district, and he has taken a lot of efforts in the field of the public health and tuberculosis. He is working as a medical officer grade A from 1996 to 2003 at PSC in Zilla Parishad Jalna. He is a well experienced medical officer, district tuberculosis officer from 2003 to 2005. Also served as TB district TB officer class 1 in 2004. He was also worked with the World Health Organization in polio project in 2005. He also worked as DRCHO in charge in Zilla Parishad from 2005 to 2007. He also worked as medical officer grade A in district training team Jalna. He also worked as medical officer grade A in civil hospital Jalna. Also has experience of post of Assistant Director of Health Services Leprosy from 2018 to 2019. He also worked as TB officer, District Tuberculosis Officer Jalna from 2019 to 2004. So he is the man of awards that he received award from His Excellency Honorable Governor and Honorable Chief Minister for best work in state in tuberculosis nutrition program and awarded for best performance in TB Mukt Abhiyan. So he's a man of awards, he is a man of work. So we welcome you, sir, to our webinar on heart matters, a holistic approach to cardiovascular diseases. So I request sir also to please uh, kindly speak few words so that he can enlighten us, our the speakers. Jagtap sir. बोलने नहीं पाएगा Dr. Ashwamedh Jagtap sir, Maharashtra Medical Council observer, will now address our delegates regarding this webinar. Hello, Jagtap sir, can you hear me? नहीं, video में नहीं दिखा. Sir, please start your video and audio so that we can see and hear you. Jagtap sir. Fine करेगा. Hello. हाँ सर. चलेगा सर. Okay sir. Thank you. Thank you. Thank you. Sir is a little bit busy with his personal work. He will join again with us. So now we'll continue with the session. Over to Dr. Zubair Khazi sir.
Thank you very much, sir.
Also.
So we are having another dynamic speaker, a very good orator from MGM Medical College, Dr. Deepak Bhosle sir. Sir is professor and head in Department of Pharmacology at MGM Medical College and consultant diabetologist at Devgiri Diabetes Center that is located in Kalda Corner, Chhatrapati Sambhajinagar, Aurangabad. Sir is professor since 2012 till date and having a huge experience of treating patients in diabetes. Since 20 years, he is serving the city of Chhatrapati Sambhajinagar, Aurangabad. He is also heading the new and most recent advanced branch in pharmacology, that is the clinical trial unit. Sir is head of clinical research unit at the MGM Medical College. Sir is faculty and resource person.
Is visible?
Yes, sir.
Am I audible
Yes, sir.
and visible both? Okay. Thank you, Zubair. Thank you very much for the kind words of introduction. And the second important thing is thank you, Dr. Hashmi, for inviting me as a faculty for this heart matters basically.
Yes.
If you see diabetes management in India, I think I'll just put forward some important things regarding diabetes in India. As per the idea of 2019, if you see the statistics, there are around 77 million people suffering from diabetes, around 44 million people who are undiagnosed, not knowing they are diabetic. If you see the projected figure by the year 2030, around 100 million people they will be having diabetes. If you see figure at 2045, it will be around 134 million. National prevalence ranges between 9 to 11%. 1 million deaths they are occurring annually. Then another important thing is if you see the definition of uncontrolled diabetes, any A1C more than 7% is considered as uncontrolled diabetes. If you see the average HbA1c of Indian population, it is 8.5. Average fasting blood glucose 150. Average post meal blood glucose level 250. If you see all these statistics, so I think definitely what topic that you kept today is very important because diabetes is considered as an equivalent to the cardiovascular disease. So that's the reason actually this topic is very important. And second important thing is if you see diabetic population in India versus diabetic population from the other world, basically, or the Caucasian population, European, American, African, whatever population, we differ from those population. In what sense we differ? Remember, Indian diabetic, they are having visceral, more visceral adiposity or visceral fat that contribute to the development of insulin resistance and that ultimately end with the diabetes. Second important thing is if you see the carbohydrate content of Indian population, it's also very high. Around 70% of our diet is rich with the carbohydrate, different kinds of the carbohydrate. So that becomes the major problem in Indian diabetic patient, and also sympathetic overactivity. Then another important thing is blunting of enteroinsular axis through which the various incretin-based therapies, which Dr. Shruti has just now discussed, acts upon. So I think these all things that makes an Indian diabetic patient different. So we need to treat our population differently based upon the guidelines which comes from our own experience or from our own population. So I think the today's topic given to me was regarding the cardiovascular outcome studies with the various SGLT2 inhibitors. But I have seen actually most of the people who are attending this program, they are either general medicine or general physician. So I just modified the topic where I think the most commonly used anti-diabetic agent is actually the SGLT2 inhibitor today. I think there are a lot of anti-diabetic agents that we are using in clinical practice, right from the bigonides like metformin. Then we are using glimepiride, glyclazide, which comes from the sulfonylureas. Then we use non-sulfonylureas insulin secretagogues like repaglanide, nataglanide that we use more often in the holy month of the Ramadan. Then we have PPAR gamma agonist like pioglitazone and lobeglitazone. We have an alpha glucosidase inhibitor drug like acarbose and miglitol. And we are having various DPP4 inhibitor like having sitagliptin, vildagliptin, linagliptin, all gliptins, they come from the DPP4 inhibitor. Then we are having GLP-1 based therapy, like I think Dr. Shruti has discussed, liraglutide, semaglutide. So all that comes from the different baskets of the anti-diabetic agent. But of late, since last maybe more than a decade, we are using one class of anti-diabetic agent, and actually that has actually opened the horizon of multiple pleiotropic benefit or additional benefit that we are getting in patients of type 2 diabetes. As we know, the definition of diabetes has evolved over the period of time. Now, if we see in the old age, we used to define diabetes when I started practice 22 years back. So that time we used to define diabetes as a diabetes is a disease of insulin resistance and insulin deficiency. But if you see currently, there has been actually huge evolution in pathogenesis of diabetes with the invention of ominous octet by Professor DiFronzo. The whole approach in management of diabetes has been evolved. It's not only the pancreas, it's a liver, it's a kidney, it's heart. There are many things. Where am I audible?
Yes, sir. Now you are audible, sir.
Yeah, I'm sorry. Actually, in between there was some technical glitches.
Yes, sir. Now you are audible.
Yes. Okay. So in this care me approach, what we are going to discuss, we are going to discuss all these aspects basically, how the various risk factor like diabetes, hypertension, obesity, dyslipidemia, or we call it as a genetic and epigenetic factor that leads to the development of endothelial dysfunction, then atherosclerosis, then ultimately end up with the microalbuminuria, then coronary artery disease or subclinical coronary artery disease, macroalbuminuria, then the various kinds of myocardial infarction, stroke, chronic kidney disease, left ventricular modeling, heart failure, end-stage kidney disease, and cardiovascular death. So this is called as actually the continuum. In what way the various genetic and epigenetic factor progresses to a cardiovascular death. Now, if you see CKD and heart failure, which are commonest manifestation in patients of type 2 diabetes, I think the diabetes is one of the leading cause for development of chronic kidney disease and heart failure. And if you see the statistics, frequency of first manifestation, CKD in 37% of the patient and heart failure 23%, whereas stroke, MI, and peripheral arterial disease, they are 17%, 14%, and 10% respectively. So you can say that CKD and heart failure, they are commonest manifestation in patients with type 2 diabetes. Then CKD in India is very high. And another important thing is diagnosis of CKD is also delayed in patients of India. There are a lot of reasons actually, and that is beyond the scope of this lecture, where actually why the diagnosis of CKD is delayed in patient. It could be poor compliance of a patient. It could be poor follow-up of a patient. It could be the consumption of various kinds of drugs, analgesics. There are so many factors that ultimately end up with CKD in Indian patients. Now, if you see the percentage of prevalence, stage 4 and stage 5, it is around 5% in stage 4 and stage 5. Stage 3, it is 20%. Stage 2, 19%. And stage 1, 51%. So, the greatest opportunity to slow CKD progression lies with the stage 3 population, which is highly prevalent stage in primary care. So this is the stage where you can act upon and prevent further progression of the CKD. So earlier intervention definitely gives significant beneficial impact on the disease progression in patients of type 2 diabetes. Now you can see from this particular figure, if there is no intervention and no one intervention versus delayed intervention versus early intervention. So you can see here early intervention. So definitely you can see that years basically they are gained by the patient. They are significant delayed 9 and no basically you can say it is 7 years. So earlier intervention definitely gives good outcome in terms of CKD outcome in patients of type 2 diabetes. Then if you see actually the EGFR and albuminuria, different kinds of albuminuria categories, like we categorize them: normal albuminuria when urinary albumin excretion less than 30 milligrams per gram, 30 to 300 we call it as a microalbuminuria, and more than 300 we call it as a macroalbuminuria. Now as you see, as EGFR increases and albuminuria increases, risk of developing CKD significantly goes high. So that's the reason actually microalbuminuria, as we say, is one of the best tests where you can actually arrest the progression of CKD to the next staging. Then about the heart failure, changes in left ventricular failure occurs over the period of time are associated with specific patient characteristics. Now, if you see heart failure per se, what are the various factors which have been associated with progression? Basically, most important is the uncontrolled diabetes, I will say. Then ISD. The third is lack of specialized heart failure follow-up. So that is also one of the important thing. And lack of specialized heart failure follow-up, then higher levels of NT-proBNP level. So that also is associated with high risk of heart failure. And factors associated with recovery are young age, then female patients, then lower heart failure severity and shorter heart failure duration, and patients having fewer comorbidities. Now, how do you define that? Basically, there are three different categories has been defined: heart failure with reduced ejection fraction, where the ejection fraction on 2D echo is less than 40%. And this is medium range ejection fraction 40 to 49%, and heart failure with preserved ejection fraction, where patient is having failure but ejection fraction more than 50%. So over the period of time, by getting proper blood pressure control, proper lipid control, proper glucose control, you can actually reverse the staging of heart failure as well. Then, if you see the presence of heart failure in patients with diabetes is associated with significant mortality. Now, you can see here, this is the data from more than 1,15,000 patients. And if we see from this particular data, survival rate in patients of diabetes without heart failure and survival rate in patients of diabetes with heart failure, you see there is huge difference actually. There is significant increased risk in a patients of diabetes with heart failure in terms of mortality, or mortality is very high in patients of diabetes with heart failure. So we need to see beyond glucose control in terms of preventing the heart failure and CKD in diabetic patients. So often we use the various anti-diabetic agent I told you, but more commonly we are using oral anti-diabetic agent today from the SGLT2 inhibitor category, where the drugs like canagliflozin, dapagliflozin, empagliflozin, rimogliflozin. So these all gliflozins, they are used in management of diabetes, and basically this molecule, they are SGLT2 inhibitor, sodium glucose co-transporter inhibitor. Now this sodium glucose transporter, they are present in proximal convoluted tubule, and they are responsible for handling the glucose. They are responsible for reabsorbing the glucose. And if you see those patients who are having diabetes, there is maladaptation into this reabsorption process, where the normal renal threshold for the glucose is 180 milligram percent, but that normal renal threshold of glucose is also significantly gone up to the tune of more, I mean, additional 20%. So that leads to the more and more glucose handling at proximal convoluted tubule, that leads to more and more absorption of glucose and hyperglycemia. So this drug basically, they inhibit the sodium glucose co-transporter and ultimately cause increased urinary excretion of the glucose. That gives actually reduction in blood glucose level, reduction in weight, reduction in blood pressure, reduction in risk of heart failure, reduction in risk of kidney failure. There are so many benefits that you are getting. That's why actually there is a battle between cardiologist, then nephrologist and diabetologist regarding use of this drug, because this drug, now I often use term drug having action on pump, pipe, filter. Pump is heart, pipe is blood vessel, and filter is your kidney. So all the target organ which are affected by the diabetes, they are significantly controlled with the use of the SGLT2 inhibitor. So is it is important to control the glucose. We need to think beyond the glucose control, act early to protect the kidney, heart, and type 2 diabetic patients, so that you can prevent the metabolic complications. So let us see what the guidelines they are saying. So treatment algorithm for patients with type 2 diabetes and CKD. So I think as routinely for management of all kinds of diabetes, we are starting with physical activity, nutrition, weight loss. We call it as a lifestyle modification. And then we add metformin, then we add SGLT2 inhibitor. Patients of CKD, but remember, any patients who is having chronic kidney disease, remember, metformin should be stopped. But those patients who are having EGFR less than 45, there you should not initiate the metformin therapy. Those who are having less than 30, don't, I mean, discontinue metformin therapy. And those who are on dialysis, don't use it. Then EGFR less than 45, reduce the dose, or rather, I will suggest sometime to stop the dose. Or many a time, we don't have those app to calculate the EGFR value grossly on basically creatinine value, because that's variable in different subjects. So creatinine value of 1.8 to 1.9 is the cutoff where actually I mean, the excretion of the drug is significantly affected. So that cutoff we can see when you are using a creatinine value. So we are using additional drug therapy which are needed for control, glycemic control, like DPP-4 inhibitor, sulfonylureas, then other molecule. The only thing that you remember, those CKD patients who have undergone kidney transplant, so it is always prudent to avoid SGLT2 inhibitor, because SGLT2 inhibitor, they have a great risk of developing genital mycotic infection and urinary tract infection. So that's the reason actually I will avoid that drug in that particular population. So treatment algorithm for patients of heart failure with reduced ejection fraction and preserved ejection fraction, as I was discussing, you can see this algorithm from European Society of Cardiology and American College of Cardiology. Both the agencies, they are endorsing use of SGLT2 inhibitor like dapagliflozin and empagliflozin in patients who are having heart failure with reduced ejection fraction, as well as those patients who are having heart failure with preserved ejection fraction. And this drug can be used as the fifth pillar, I will say. While managing heart failure, we are using mineralocorticoid receptor antagonist, we are using valsartan sacubitril combination, we are using ARB, we are using loop diuretics, and definitely over and above that, I will use SGLT2 inhibitor. So that's why we often call it as the fifth pillar of management of heart failure. Then again, if you see the use of glucose lowering medication in management of type 2 diabetes. Now, this is the slide from the American Diabetes Association standards of care. Now, if you see here, SGLT2 inhibitor, they can be used in patients who are having cardiovascular disease, or those who are having atherosclerotic cardiovascular disease risk factor, or those who are having heart failure, those who are having CKD, all across the different spectrum of population. This drug, it can be effectively used. And of late, actually, dapagliflozin is a patented molecule available at cheaper cost. You can benefit your each and every patient with the use of SGLT2 inhibitors. Now, what is the evolving role of dapagliflozin as leading treatment option among the SGLT2 inhibitor? So, I think dapa, cana, empa, so all gliflozins, they are having their, concrete data supporting in terms of their cardiovascular safety, renovascular safety, or improvement in metabolic parameters. These are the names of the various studies like empiric outcome study, canvas study, gradon study, emperor reduced, emperor preserved, empa kidney. These are all studies, they are conducted on huge population across the globe in different population, which has proved the cardiovascular safety of this particular molecule. Now, dapagliflozin offers powerful glucose reduction across the baseline. Now, you see, whatever the baseline A1C, see, more the baseline A1C, more pronounced reduction in HbA1c you will see with the use of dapagliflozin. You can see even at lower baseline A1C 7.92, you see around 0.9% reduction in HbA1c over the period of 24 weeks. Then a reduction in HbA1c was sustained over the period of 4 years, which is again very important thing. Whatever drop down in HbA1c you are getting, that HbA1c is sustained over the period of 208 weeks. That is almost a duration of 4 years, which indicates that this drug, they are not only lowering the HbA1c to the baseline, but also maintaining it to a very longer duration of time. Then dapagliflozin in patients of cardiovascular events or having cardiovascular risk factor. Now, this is, I think, the landmark study conducted with dapagliflozin, which has shown the cardiorenal benefit in patients with type 2 diabetes and early renal disease. Total, they have studied more than 17,000 patients, and they have randomized as 1:1 to DAPA 10 milligram versus placebo, and the median follow-up against you 4.2 years. And these were the categories related to the proteinuria basically. See, the normal proteinuria 68%, microalbuminuria 23%, and more than 300. That is, macroalbuminuria or proteinuria 7%. Now, you can see the renal specific composite outcome 48% relative risk reduction of the renal specific outcome, 41% reduction of renal specific outcome in patients having microalbuminuria, and greater even in those patients who are having overt proteinuria. And so do is true with the composite of CV death or heart failure. You see, even overt proteinuria risk reduction is 23%. So dapagliflozin demonstrated consistent cardiorenal benefit in patients with or without albuminuria. Now, cardiorenal benefit of dapagliflozin represents the patients of your everyday practice. We see quite often basically it is not only a dapagliflozin. It was actually the studies conducted like empiric outcome study for empagliflozin, that has also given same kind of a result. Though there are, some differences in terms of figures, but definitely if you see all the molecules, they are equally effective in managing cardiorenal and metabolic risk. So dapagliflozin has shown both preventive and therapeutic effect in cardiorenal disease in type 2 diabetic patients. You can see here multiple severe risk factors: smoking, overweight, hypertension, dyslipidemia, then increased risk of heart failure, CKD, cardiorenal event, and repeated cardiorenal event. So all across the spectrum of different cardiorenal and metabolic disease, you see it has significantly benefited in terms of reducing the mortality of the patients. Then CKD patient, now this is one of the DAPA CKD patient which was conducted in more than 4,300 patients, where DAPA versus placebo was tried for 2.4 years in patients who are having CKD. So you see 68% of the patients with type 2 diabetes, then mean HbA1c at baseline was 54 millimoles. Then this is the basic things. I mean, broad range of baseline EGFR 725 to 75, and 25% of 29% of the patients they were taking the metformin, and 37% they were taking the insulin. So these are the outcome basically. Primary composite outcome, you see 39% relative risk reduction of renal outcome, all cause mortality reduced by 31%, and composite of CV death or heart failure is also reduced by 29%. So the first dedicated CKD trial to reduce all cause mortality risk. So that's the since that time actually there is 20 risk reduction of CV death or hospitalization for heart failure or urgent heart failure visit to a center. So all across it is highly effective. Then dapagliflozin heart failure and deliver pooled analysis design. Now this is again data from more than 11,000 patients. And if you see, purpose was to examine the effect of dapagliflozin across the left ventricular ejection fraction range, given the attenuation seen in patients with higher left ventricular ejection fractions in other heart failure medication trial. And the outcome was CV death, the all-cause death, then total hospitalization for heart failure, then major adverse cardiovascular events, then composite of CV death, MI, stroke, CV death, and heart failure. So these were studied. And if you see all across these parameters, CV death, all-cause mortality, then total heart failure, hospitalization for heart failure, then first hospitalization for heart failure, CV death, all are significantly improved with the use of dapagliflozin. So while intensifying treatment with dapagliflozin, not all metformin formulations are same. So that's the reason actually need for a right formulation and technology to address the GI issue with the metformin combination. As we know, when we are combining metformin with SGLT2 inhibitor, metformin is one of the drugs which is known to cause vomiting, nausea, abdominal discomfort, diarrhea, or even host complex. So this is, I think, is one of the major issue related to the metformin and alpha glucosidase inhibitor, because of which their tolerance by the patient is very poor. So that's why actually the gel matricial diffusion technology that is called a GMSD has been one of the technology which is used for combining this metformin with SGLT2 inhibitor in this particular combination, which has significant impact. So this combination basically has significant impact on reducing HbA1c, improving the side effect profile by using this particular technique of GMSD, that is gel matricial diffusion technology. We can benefit patient in terms of the adverse effect. Then this is last one or two slides. Basically, not all the SGLT2 inhibitors they are similar. Now you see, this is a numerical difference that we find. You may vary your personal experience might vary from this particular data, because the major chunk of population that has been studied in this particular study, they are from the other world, and there are representation of Indian population in this study, but major chunk was from the other world. So glycemic control, you see here, this particular dapagliflozin has benefit and scores over the empagliflozin. You might see some other data where EMPA might have been shown superior to the dapagliflozin. But by and large, if you see all the molecule, empagliflozin, dapagliflozin, and canagliflozin, all of them they are superior. The most important thing that I've forgotten to mention is this is the only drug which gives significant weight loss in diabetes. See, I have a personal experience of using dapagliflozin, or for that matter, all gliflozin. They reduces weight significantly. Initial 3 months, you get 3 to 4 kg weight loss. and that occurs because of the glucosuria. I mean, by inhibiting the sodium potassium ATPase pump, there will be increased urinary excretion of the glucose, and that glucose or calorie loss contribute to the weight loss in patients of diabetes. And even I am using this particular molecule in treatment of obesity or pre-diabetes or patients who are having metabolic syndrome. There we are using it very commonly for treating our routine patients. So dapagliflozin, as I told you, there are so many pleiotropic benefits. It is useful in heart failure, useful in diabetes, useful in chronic kidney disease. And as mentioned in this busy slide, there are so many benefits that you are going to get with the use of this particular class of an anti-diabetic agent. But truth in pill, debate on original compared to generics. So this has been one of the issue. But of late, actually, I'm using this molecule right and left, no matter whether patient is buying the drug from Jan Aushadhi shop or buying it from the branded molecule from the branded. All of them, they are comparable, and I will say it is always prudent to use this kind of molecule in treating our diabetic patient. Second important thing being the low risk of hypoglycemia. Remember, these drugs, they don't have pancreatic action. Don't have pancreatic action. As they don't have pancreatic action, so there is minimal risk of hypoglycemia. And if you are adding this drug on the top of sulfonylureas or on the top of insulin, you need to
The subject. Thank you very much, sir. I Dr. Shafi, sir. The subject. Thank you very much, sir. I Dr. Shafi, sir, to kindly present a memento and certificate to sir. Definitely, it will reach to you tomorrow morning.
Thank you very much, sir, for your excellent talk.
Thank you, sir. Thank you.
Thank you very much, sir. Thank you.
Thank you. Thank you, Zubair. Thank you, sir. Thank you very much.
Thank you very much, sir. To continue with our talk, talk, I would now call upon our next speaker, Dr. Abhimani, sir. Dr. Abhimani, sir, is a diabetologist practicing in Pune. He is a professor in Department of Community Medicine at Kashibai Navle Medical College. He has done his MBBS from LTN Medical College, Mumbai, and MD from Tamil Nadu Medical College, Tirna Medical College from Mumbai. He has done his diploma in diabetes from CMC Vellore and CCEBDM from PFI. He is consultant diabetologist at Daiba Life Diabetes Specialty Center in Pune. Has experience of working as HOD, medical superintendent, vice principal academics, and MEU coordinator. Sir is a member of Board of Studies of SOA University Bhubaneswar, Orissa, life member of IAPSM and many other societies including RSSDI. Sir has total of 54 publications in Index National and International Journal in his name. Sir is associate editor of International Journal of Public Health Sciences, Scopus Index Journal, that is, and is on editorial board on and member of 5 indexed journals. Sir, you can start sharing your screen and unmute yourself.
Is the screen visible?
Yes, sir, we can see your screen.
Am I audible?
Yes, sir.
Okay, thank you.
Yes, sir.
Very good morning to all the delegates. Before I start my presentation, I would like to thank Dr. Shafi and his team, the Elite Academy, for inviting me for this wonderful session of the webinar on heart matters. So thank you
Allied Academy team. So the topic of my presentation is what is the role of diabetes mellitus in cardiovascular disease. So what is the pathophysiology, how research has evolved into this, why diabetic patients are more at risk of cardiovascular diseases, that is CVDs. And there are few novel molecules. Just now, Dr. Deepak Bhosle sir has elaborated on SGLT2 inhibitors. So, a few novel molecules have come into market which have changed the game of diabetes management, like that. So, to introduce, we all know that there's a global epidemic of type 2 diabetes mellitus and its complications will be a major threat to public health, because now we are seeing young diabetics. So definitely they are going to live for a longer period of life with diabetes and may land up with complications. Cardiovascular diseases remain the leading cause of death globally, and these diseases remain a leading cause of morbidity and mortality, not only in general population, but they are higher in people with type 1 and type 2 diabetes mellitus. And we all know that now the onset of type 2 diabetes at young age, that is less than 40 years, leading to a greater number of life years lost, has also become increasingly common. And this, as Sir Dr. Bhosle sir has said, it confers a wide spectrum of risk and is not necessarily a CVD risk equivalent. Okay, so therapy has to be individualized. Okay, for each patient, and health conditions like dyslipidemia, hypertension, obesity, and other factors of the risk are frequent in diabetic persons and raise the likelihoods of heart attacks. We all know there is a strong association between DM and CVD, and among the patients of diabetes, CVD is mostly responsible for mortality. The major CVDs associated with this diabetes include ischemic heart disease, heart failure, stroke, coronary artery disease, and peripheral artery disease. CVDs can result in death for at least 50% of patients with type 2 diabetes. And CVDs are of great concern in the disease progression and prognosis of type 2 diabetes. So, management of CVDs is very important right from the diagnosis of type 2 diabetes till this is a graphical representation of number of diabetic people projections, okay, worldwide from 2021 to 2024. There will be across the globe 46% rise in number of people with diabetes mellitus, and if you see Southeast Asia, it will be 68% rise in the population of diabetic people. So we have to keep this in mind and think what would be the role of diabetes in CVD and how this CVD risk can be reduced and lives can be saved. This is another table that tells you the prevalence of CVDs among diabetic patients. So if see the figures of 2016, then 2017 and 2019, okay, definitely the prevalence has come down, but all CVDs prevalence is increased, that is 34.8%. The other CVDs like coronary heart disease, artery disease, heart attack, stroke, heart failure, and PAD, that is peripheral artery disease, have been better management of diabetes mellitus, early identification of these risk factors, and probably awareness among patients to take the treatment uh, and treatment compliance. This is another graphical representation of diabetes cardiovascular risks. We all know these risks that are seen in diabetic patients. Coronary heart disease, the prevalence ranges from 14 to 21%. Heart failure, the prevalence ranges from 19 to 26%. Peripheral artery disease, that is PAD, ranges from 16 to 29%. And stroke prevalence 8 to 12%. And we know all other microvascular complications like retinopathy, the prevalence is 34%. CAN, that is neuropathy, cardiac autonomic neuropathy and peripheral neuropathy, the prevalence ranges from 31 to 73%. and nephropathy, the prevalence is 29 to 61%. So these are the figures, and definitely all these cardiovascular risk or complications of diabetes can be identified early in the course of diabetes. So we have a lot of new gadgets, new equipments, new tests that can help us diagnose these conditions early. And at every visit of each diabetic patient should be screened for these likely cardiovascular risks. Okay, so we know that heart disease and diabetes, what is the role or what is the relations? Adults with diabetes are up to 2 to 4 times more likely to have cardiovascular disease than people without diabetes. And remember, this is 2017 figure given by IDF Diabetes Atlas, that cardiovascular disease is the most common cause of death among people with diabetes, which is preventable and reversible. And for cardiovascular disease risk, among modifiable risk factors, one is diabetes mellitus. So, proper glycemic control and proper management of diabetes, along with modifying the other risk factors, will definitely reduce the cardiovascular disease burden in community or in population in future. So what increases the risk of CVDs among people with diabetes is uncontrolled glycemia or hyperglycemia, disorders of fat metabolism and high cholesterol risk of. So there is a role of uh, ethnicity also in that, and high blood pressure. So these are the different risk factors that make a diabetic patient more prone to have CVDs than non-diabetics. So definitely there are pathophysiological changes that contribute to this high risk. And we have a session at the end. What is the pathophysiology of CVDs in diabetic, which will be taken by Fatima ma'am. Okay. So how does DM lead to more of CVDs? The one possible mechanism is hyperglycemia. Hyperglycemia can damage blood vessels. We all know now. The risk factors, because many diabetic patients have other risk factors also for CVD. So diabetes itself is a risk factor for CVD. Plus the patient has other CVD risk factors also, like high blood pressure, obesity, and dyslipidemia. So diabetes also leads to inflammation, which can contribute to CVD. This inflammation can cause endothelial dysfunction. Then high oxidative stress that is found in diabetes patients can also contribute to CVD and cardiac fibrosis. So various mechanisms have been evolved or have been identified in diabetics that lead to cardiac fibrosis, which can also contribute to CVDs. So these are the four possible mechanisms that have been identified. And we know that there's an exchange of risk factors among type 2 diabetes and cardiovascular diseases. The risk factors for both type 2 and CVDs are physical inactivity, high blood pressure, poor diet, smoking, obesity, dyslipidemia, and metabolic syndrome. And definitely, there are direct effects of hyperglycemia on the individual's body that leads to arterial stiffness. Endothelial dysfunction is a major contributor, high oxidative stress, platelet activation. So, hypercoagulable state is seen in diabetic patients. Then, inflammation is seen. So, high CRP levels are seen, metabolic dysfunction, and metabolic syndrome. So, all these factors lead to cardiovascular disease, or diabetic risk factors can lead to CVDs like that. So this is a pathogenesis of CVDs among diabetics. So this will be talked probably in detail by Fatima ma'am at the end. So hyperglycemia and all these mechanisms have been identified that lead to high prevalence of CVDs among diabetic patients. So I will not go into detail. So what is the link between DM and CVDs? So we all know that CVD is the most prevalent cause of morbidity and mortality in diabetic people. The figures of US are very high, that is 1.7 times higher among adults CVD deaths with DM than those without DM. And this high CVD death rate is because of high stroke and MIs. Okay, so this increased risk of CVD mortality in diabetic patients is found both in men and women. So there's no gender difference between two. The relative risk for CVD morbidity and mortality in adults with diabetes, it ranges from 1 to 3 in men and 2 to 5 in women compared to those without diabetes. So CVD is the most prevalent cause of mortality and morbidity. And since it is the most prevalent cause, the primary goal of diabetes treatment should be to improve the cardiovascular risk of diabetic patients. So it's not just the controlling the sugars of diabetic patients, we have to keep a watch on the cardiovascular risk of diabetic patients. Suppose he is having hypertension, so treating hypertension accordingly. Suppose the patient is having dyslipidemia, correcting the dyslipidemia. He has another risk factors like obesity, motivating the patient about physical activity. Okay, so all this should be the primary goal of diabetes treatment, not just controlling the hyperglycemia. So individualized therapy is a must in diabetes management. Okay. So one challenge associated with treating DM and reducing CV events is the complex and multifaceted nature of the relationship linking DM to CVD. Okay. And CV risk factors like other risk factors like obesity, hypertension, and dyslipidemia are common in patients with DM. So these risk factors have also to be taken care while managing diabetic patients or treating diabetic patients. Many studies have reported that several factors, including oxidative stress, increased coagulability, endothelial dysfunction, autonomic neuropathy, nobody thinks of, are often present in patients with DM and may directly contribute to the development of CVD. The high risk rates of CV risk factors and direct biological effects of diabetes place diabetic patients at increased risk of developing CVD right at the time of diagnosis till their progression with diabetes and contribute to increased prevalence of myocardial infarction, revascularization, stroke, and CH, congestive heart failure. Due to the complexity and numerous mechanisms, it is crucial to focus treatment to what will have the greatest clinical impact on improving CV outcome. So now, whatever molecules are coming for diabetes treatment, their CV outcomes are studied, whether they improve the CV outcomes. And the latest two molecules, just now sir has said, SGLT2 inhibitors and GLP-1 agonists. So these molecules have revolutionized the management of diabetes, and definitely they have proved clinical benefits in improving CV outcomes among diabetic patients and in those patients who have CV risk factors. Okay. So DM and insulin resistance are also associated with overexpression of many cytokines by adipose tissues like TNF alpha, interleukin 1, interleukin 6, leptin, fibrinogen, and angiotensin. So there is also increased levels of CRP that may contribute to endothelial dysfunction, and patients also have decreased adenopectin production, which may result in diminished endothelial functions. So many possible mechanisms have been identified and explained for high CVD risk. So again, obesity, this is again a pictorial chart that tells obesity leads to insulin resistance, and insulin resistance can have so many manifestations like NAFLD, cardiovascular disease, hypertension, prothrombotic state, and dyslipidemia in obese patients. Okay, let us now see how diabetes and other CV risk factors are intertwined in each other, how they are linked to each other. So CV risk factors and CVD risk. The first risk factor is hypertension. Now, if a diabetic patient has hypertension, why he is placed more at risk of CVD? So we all know that hypertension is very common in all the patients of type 1 and type 2 diabetes mellitus, and the prevalence rates are from 30 to 60% respectively. And hypertension among diabetic patient, okay, is closely tied to the development of diabetic nephropathy. So we have to take care of a patient who is a diabetic and also a hypertensive coming to your OPD. whether he is landing up into development of diabetic nephropathy, how is glycemic control, whether it is good or not. So usually we do certain tests once a year, like serum creatinine, albumin creatine ratio, at least for those patients who are have a long standing diabetes, more than maybe 5 years of diabetes. So yearly we make it mandatory for all the patients to do these investigations. We explain them the importance of these tests, because these complications are reversible. Okay, so chronic activation of RAS often progresses to hypertension, placing added stress on the glomeruli and causing additional damage to the nephrons of diabetic patients. Okay, and if we don't treat this, diabetic nephropathy can progress to a nephrotic syndrome that is characterized by proteinuria, a hypercoagulable state, and hyperlipidemia. So all these will contribute to increased risk of CVD seen in diabetic patients with renal dysfunction. The next risk factor is dyslipidemia. So how dyslipidemia in diabetic patients contributes to more CVDs? Diabetic patients are at increased risk of developing dyslipidemia, and one mechanism underlying this connection of diabetes, dyslipidemia to CVD is increased free fatty acid release present in insulin resistant fat cells. Okay, so high levels of free fatty acids promote triglyceride production, which in turn stimulates the secretion of ApoB and very low density lipoprotein cholesterol. So very LDL, VLDL cholesterol. So high levels of ApoB and VLDL have both been tied to increased risk of CVD. Okay, and not only this, the hyperinsulinemia that is seen in diabetic patients with is also associated with low HDL cholesterol levels. Low HDL cholesterol, we tell patients it's good cholesterol. So its levels should be more than 40 in a diabetic patients. So low HDL levels again is due to hyperinsulin. So all this high circulating free fatty acids leads to hypertriglyceridemia, increased stimulation of ApoB and VLDL cholesterol, and decreased HDL levels. All have been appreciated in patients with DM and likely contributes to the high prevalence of CVD in diabetic patients. So we have to take care of this, and we have to actively manage dyslipidemia in diabetic patients. The next CV risk factor for CVD is cardiomyopathy. So diabetics tend to have a greater cardiac mass, particularly left ventricular mass, than those without DM. Okay. So left ventricular hypertrophy is a common finding in 2D echo. They also tend to have slightly diminished diastolic function compared to non. It's not only diminished diastolic function, but there's a factor that they have a systolic dysfunction also like that. So one mechanism for this diastolic dysfunction or is increased triglyceride synthesis in patients with DM that leads to increased myocardial triglyceride content. And this associated with lipotoxicity and altered calcium hemostasis in myocardium negatively impact diastolic function. And also, I said systolic dysfunction may be related to myocardial sympathetic innervation and impaired contractile reserve. So, both systolic and diastolic function that is seen in diabetic patients also place them at an increased risk of heart failure. And now we are seeing more prevalence of heart failure, particularly heart failure and with preserved ejection fraction. This is higher in diabetic patients than in general population. So we all know now the diabetes independently alters the cardiac structure and function, okay, of the heart. The next CV risk factor for CVD is cardiac autonomic neuropathy, that is CAN. So CAN is also common among patients with diabetes and is correlated with an increased mortality rate from CVD. Okay. So this clinical manifestation of CAN, the clinical manifestations are resting tachycardia, postural hypotension, exercise intolerance, abnormal coronary vasomotor regulation, increased QT interval, and perioperative instability. So we have now equipments that can identify cardiac autonomic dysfunction also. So those equipments can help you in identifying CAN early. The clinical manifestations of CAN are related to an increased risk of renal disease, stroke, CVD, and sudden death. Okay. So the mechanism of CAN is dysregulation of autonomic nervous system with increased sympathetic activity and elevated inflammatory markers. This is same, and that results into CAN among diabetic patients. Okay. So ANS dysfunction can lead to arterial stiffness, left ventricular hypertrophy, and ventricular diastolic dysfunction. And incidence of CAN increases with age. And if the patient is having inadequate glycemic control, which places him at higher risk of developing CAN and CVD. So as the duration of diabetes increases, always think of this CVD risk factor. The next risk factor is myocardial infarction among diabetic patients. Okay, so these patients are at higher risk for development of coronary artery disease with a higher incidence of MI in patients with diabetes. Not only they have a higher risk of developing, but after MI, diabetic patients have higher rates of morbidity, mortality, and reinfarction than non-diabetics. Okay, the higher risk of high incidence of MI in patients with DM is attributable to increased coagulability. This is what. And even silent MI is also responsible for higher rates of MI seen in diabetic patients. So silent ischemia is again more prevalent in patients with DM, that is 10 to 20% than those without diabetes. So coming to how we can prevent these cardiovascular diseases in type 2 diabetes patients. So CVDs can be prevented or delayed by controlling not only blood glucose, but we have to take care of other CV risk factors like blood pressure, cholesterol, lifestyle changes, very important, such as stopping smoking, eating healthily, and increasing physical activity. So in our prescriptions, we counsel the patient during each visit to change the lifestyle behaviors. If they are smokers, we tell them to decrease smoking and stop smoking. We give them a diabetic diet chart so that they eat healthily and there's no fluctuations in blood sugar level. Treatment compliance is assessed at every visit, and whether they are physically active or not, that is again monitored. So it's not only managing sugar levels, but overall management of all other risk factors in a diabetic patient is very important for preventing CVDs. So how we can do for primary prevention? Preventing or delaying new onset CVD in patients with T2DM. So prevent the risk factors or early detection of CV related risk factors in community based high risk populations. So while taking history, if you come to know that the parents have a CVD or they have a CVD event or they are having established CVD, screen the next generation to identify CVD related risk factors early. Tell them they have a higher risk of CVD because their parents have. Counsel them, start treatment. And we have now new molecules for diabetic management. Those are encouraged for use in such patients. Early diagnosis of type 2 diabetes in subjects without CVD is also needed. Okay. And secondary prevention is the cornerstone for management of diabetic patients with established CVD, or at least if they have risk factors for CVDs. Individualized glycemic targets and glucose lowering therapies in combination with comprehensive CV risk reduction is very important now. Okay, and document this CV risk reduction. Document whatever counseling you are giving. We write every aspect into our prescriptions, like follow diabetic diet. What is the ASCVD risk? What medicines are given? Treatment compliance. Why it is important? Counseling to reduce and stop smoking. Physical activity, promoting physical activity. All these advices are written in our prescription. Patient centered care must be considered in decision making for secondary prevention among type 2 diabetes patients with established CVD. Very important. And this includes individual medical history. So spend some time on medical history, lifestyle behaviors, and CV and metabolic risk factors. Okay. So CVD risk assessment aims to provide appropriate regimens for prevention and treatment of CVD. So we also do this CVD risk assessment in each visit. So some tools are available for risk stratification for primary prevention in patients with type 2 diabetes. This is given by American College of Cardiology and AHA. The risk estimator plus tool can be used to calculate 10-year ASCVD, atherosclerosis, cardiovascular disease risk, and provide individualized advice for patients who are aged between 40 to 79. Certain parameters, certain things are needed. It's available online also. You can go to the site and you can put the values and it gives a 10-year ASCVD risk. And we document that in our prescription. Okay. Many times the patients are not ready to take some medicines. Okay. So we document all those things. Then there's another CVD risk stratification given by ESC, which is divided into moderate, high, and very high risk levels for patients with either pre-DM or established DM based on other comorbidities and duration of diabetes. Okay. The risk estimator plus that considers age, if the age is more than 40 years, what is the gender of the patient, what is his current blood pressure at the visit, what are his blood lipid levels and history of diabetes, whether he's a smoker and what drugs he's taking. So this risk stratification for secondary prevention uh, for more than 75 years, diabetes, whether he has diabetes, hypertension, whether he has PAD, previous stroke, previous coronary artery bypass graft, history of heart failure, whether he's a current smoker, and renal dysfunction. So all these parameters can help you in risk stratification. And the comparison benefits, like between the two risk stratification categories, would help us to facilitate the choice of individualized care in patients with T2DM and CVD, like that. So glycemic control is very important, and definitely we have to follow the targets. Now, since we are going for individualized glycemic control for each patient, the targets are different for different populations given by EDA. Like in pregnancy, less than 6 is the target of HbA1c. But see to it that the patient does not suffer significant hypoglycemia. For all other patients, less than 7 or 6 to 7 is ideal. And for elderly patients, even less than between 7 to 8 is also okay. And patients with elderly who have ASCVD or evidence of CVD, 7 to 8 is okay. But younger patients with short duration of DM and no evidence of CVD, the HbA1c targets are 6 to 6.5. So more tighter control of glycemia for younger patients, and little relaxed criteria for all those elderly patients with other comorbidities with established CVD risk factors, have significant hypoglycemia, they are older and frail, elderly, etc. So these are the different targets of HbA1c, and we also follow this in our current practice. So this is another graph based on coronary calcium score chart. So we know that diabetic patients, if you see the middle bars, if you see diabetes mellitus, the CAC scores are higher, and the annual CHD event rate is also higher among diabetic patients with a higher CAC score of more than 400. So more than 400 CAC score means severe calcium deposits are seen in coronary artery disease on CT scan. So what happens? CVD and other risk factors, if we are controlling the risk factors. Okay. So what happens? So the red color is no risk factors are controlled, and what is the event rates? So any risk factor is controlled. Definitely the CVD events and CHD, coronary heart disease events, reduce to more than 20%. If we control two risk factors, definitely the incidence of these events decreases. And if all three, at least three risk factors are controlled, the risk reduction is more than 50%. So always identify the CV risk factors among diabetic patients and aim to reduce the risk factors as much as you can. Okay. Now, what are the diabetes and CVD facts? We all know that more than 65% of all deaths in people with diabetes are caused by cardiovascular diseases. Heart attacks occur at an earlier age in people with diabetes, often result in premature death. We know this. Up to 60% of adults with diabetes have high blood pressure, that is, they are hypertensive also. And all nearly all adults with diabetes have one or more cholesterol problems, such as high triglycerides, low HDL, and high LDL, like that. So if you think of diabetes as one risk factor for CVD, hypertension as other risk factor, and dyslipidemia as third risk factors. If you control all the three, definitely you are decreasing the CVD events. The good news is that by managing, we say ABCs, we educate the patient. It's not only controlling the sugar levels, but ABCs of diabetes. People with diabetes can reduce their risk for heart disease and stroke. Or patient sometimes says, yes, I have diabetes. My father had a heart disease. Okay, he had an MI or he died because of cardiovascular disease. So what is the risk I may have? So we screen them and we say, yes, you have to take care of your ABCs. So A stands for A1C. Keep the targets of A1C as given by ADA. B stands for blood pressure. We have to keep his blood pressure. Target blood pressure is less than 140 by 90. And if the patient is young, we even aim less than 130 by 90. C stands for cholesterol. So dyslipidemia has to be controlled. And now we tell two more B's. That is, if the patient is obese, reduction in obesity or BMI, and blood sugar levels. Okay. So, what are the guidelines based care for prevention of CVD among with diabetes mellitus? So, we know that the risk factors for CV. I have enlisted 8 risk factors for CVDs among diabetic patients. And what are the guideline based care? What level of evidence is available and what advice can be given to the patients to reduce the risk of CVDs among them. The first is physical inactivity. So, what advice is given with regards to physical activity? Yes, this is a evident that we advise the patients at least 30 minutes of exercise, moderate intensity exercise per day, or 150 minutes per week, moderate intensity exercise over at least 3 days per week, and not more than 2 consecutive days without exercise. So they can take 1 day break in between, but not more than 2 days break. Okay. And moderate intensities that they should achieve the maximum heart rate, that 50 to 70% of that heart rate should be maintained with whatever intensity physical activity they are doing. With regards to nutrition, definitely there's a lot of evidence uh, that Mediterranean diet improves better glycemic control and CVD risk factors. So, what is this Mediterranean style diet? Is consumption of fruits, vegetables, legumes, whole grains, and dairy in place of other carbohydrate sources. And now, carbohydrate monitoring is an important strategy for glycemic control. And we are teaching our patients how to monitor the carbohydrate, what are low glycemic index foods. Our diet chart is basically dividing the food items based on glycemic index. We educate them, we give them e-chart on their mobiles, and they can monitor the carbohydrate content what they are taking, and we tell them to monitor at home also, like that. And the next risk factor is weight management. So we counsel overweight and obese patients that lifestyle changes can lead to a sustained 3 to 5% rate of weight loss and clinically meaningful health benefits if they reduce the weight by 3 4 kgs or fat loss.
नहीं वो चल रहा है, मैंने रिस्टोर कर दिए थे। हाँ लोड हो रहा होता सर। हाँ आ गया है। हाँ आ गया। कर दिया कर। कर दिया। हम्म
ml. And whenever like shock is being managed, we considered like 30 ml per kg. That is, we usually give over the 3 hours, and that is to be watched. Then static dynamic, as the this slide says, that dynamic monitoring techniques, these are available. And static, what clinically we can see that tachycardia we can see that there, then urine output we manage, then central venous pressure we do manage. But they have their own advantages and disadvantage of static parameters that we monitor. In the dynamic monitoring system, pulse pressure variation, this how do we define this? Pulse pressure variation measures variation in the pulse pressure, that is difference between the systolic and diastolic pressure during respiratory cycle in mechanically ventilated patients. This pulse pressure variation we'll be giving in the next slide how we calculate that. Arterial monitors we are using, on that basis we can this is perfectly in the mechanically ventilated patients. On spontaneous breathing patients, the predictive value can be less. That's why your patient has to be on the control systems. It reflects changes in the left ventricular preload. It is a parameter to monitor the preload that matters. Then high pulse pressure variation indicates fluid responsiveness, meaning that patient is likely to benefit from the fluid administration. But always in the practice, remember that any monitoring system is there, or patient is fluid responsive means always you will be giving ample of fluid. It's not that way. You have to be vigilant on the clinical parameters and all these figures. Just don't treat the figures. You have to be thoroughly monitor all the systems how they are working. You have to de-escalate and escalate your whatever parameters you are monitoring, and you have to adjust pharmacological therapies that way. Always keep that in mind. And this is applicable in mechanically ventilated patients without arrhythmias. Then stroke volume variation. As you all know that stroke volume is the ejected output of just the changes in stroke volume during respiratory mechanical ventilation patient, calculated as a percentage of variation between the maximum and minimum stroke volume over a single respiratory cycle. Again, stroke volume variation more than 13% indicates fluid responsiveness in most of the patient. Useful for optimizing preload. Again, this is a parameter that is used in the preload detection and guiding the fluid therapy. This is one of the parameter nowadays, like we are using in the ICUs to monitor the fluid therapy. And what it requires advanced hemodynamic monitoring systems like PICO and LEDCO. These are the advanced hemodynamic monitoring systems like pulse contour cardiac output monitoring system that has been developed with the research, and we can use these advanced systems in our ICU. Then this is passive leg raise test. Again, the advantage of this test is that this can be applied in the spontaneously breathing and mechanically ventilated both the patients. Or this is a reversible self volume challenge that transiently increases venous return and cardiac output by mobilizing blood from lower limbs to the central circulation. This is non-invasive, easy to perform. What you need is with 2D echo, you can that percentage increase in the cardiac output you can monitor. Then it involves raising the patient's legs up to like 45 degrees while lying supine. If LR leads to a more than 10% increase in the cardiac output measured by Doppler, the patient is likely to be fluid responsive. Again, you all remember that this likely to be fluid responsive means you have to be always vigilant. Initial boluses you can give, then according to the improvement in the condition of the patient, because many of the times there can be the leak syndromes in which you say that there can be fluid responsiveness, but because of that leak, that fluid may go in third space, and that can have deleterious effect on your patient. Then volume responsiveness with 2D echo, that is cardiac echo. Again, this is the diagrammatic diagram that's showing passive leg raise test, and that 10 to 15% increase in the cardiac, that is measured with 2D echo. And there you can then, as we discussed, that cardiac output is heart rate into stroke volume. Then measuring volume responsiveness with 2D echo, like this pulse pressure variation and stroke volume variation. Stroke volume variation is better than pulse pressure variation. You can see these are the pictorial views of what we see in the arterial monitors. Like the here you can see that this pulse contour, that is it is varying. This is the like highest, this is dialysis in this way. This is like this is the highest point, and this is the diastolic lowest points, and you will be taking both the things in the next diagram while showing that how it is calculated. Then passive leg raise. These are the various components that leads to, and mainly in the passive leg raising test, the femoral component that leads to increased preload, and that leads to that variation in the contours of the the pulse that you can see on the arterial monitor or the advanced cardiac monitors like Pico. Here you can see that this pulse pressure maximum here, that is pulse pressure variation will be the pulse pressure max minus pulse pressure minimum. This is the minimum pulse pressure, that is the systolic pressure minus diastolic pressure. This is a maximum, and this is a, you can see that this is pulse pressure that is varying. This is a minimum, and average of the max and minimum, like that is pp max plus pp minimum divided by 2, that will be taking, and normally it is less than 12%. If it is like 15 16, and then you say that it is a like this patient is likely to be fluid responsive, and you can give like fluid in those patients. Then stroke volume variation, these are calculated in the advanced monitor, already calculated values, like software gives you that way. The area under a curve, here the stroke volume maximum, this is the maximum stroke volume per beat, and this is the minimum stroke volume. You can see that again SV max minus SV minimum divided by the SV mean, that is the SV max plus SV mean divided by 2. Again this variation, if it is less than 10%, there will not be the use that you will be giving fluid in those patients. Again, if it is more than 12%, more than 13%, then you can give fluid in your patient. Predictive value of pulse pressure variation and SVV. Different studies have found like it is in the range of like 0.84 to like 94. Particularly this study by Young in 2014, it is 1807 patients. Again, it is like when the tidal volume that is delivered on the mechanical ventilation that is low, like most of the ARDS patients, we use less tidal volume, that is 6 ml per kg, then this predictive value may be less in those patients. That's why and we may not be able to calculate these variations like pulse pressure variation or stroke volume variation in those patients accurately. Though these patients need to have the tidal volume more than 8 ml per kg, where you can calculate it accurately, and you can use that parameter to give the fluid in your patients. That is the mandatory requirement for using these parameters. Limitations of pulse pressure variation and SV variable. You can see that low heart rate, bradycardia, very high respiratory rate, that can hamper your these measurements. Then irregular heartbeat, that can arrhythmias, that can hamper your measurements. Mechanical ventilation with low tidal volume, that can you may not be able to measure it accurately, and you cannot properly advise fluid to your patient. Then increased abdominal pressure, like pneumoperitoneum, again there will be difficulties in measuring these parameters. Open thorax, then spontaneous breathing. In the spontaneous breathing, we have seen that leg raising test that can be helpful. This we have seen that because most of the ARDS patients, we need the lung compliance is very low, and we need to give tidal volume less than 6 ml per kg, and in these patients the accuracy of pulse pressure variation and stroke volume variation, that can be less. For this, like this is like Dr. Maitra's paper. She is the past president of Indian Society of Critical Care Medicine. She has published this, like the changes in the pulse pressure variation or stroke volume variation after tidal volume challenge. Like most of the ARDS patients, we are giving less than 6 ml per kg. Then transiently, we like they hypothesized that transiently increasing the tidal volume from 6 ml to 8 ml per kg and measuring the pulse pressure variation may help unmask the responders. transiently you do on the mechanically ventilated patients, and there again there is a increase in the pulse pressure variation or stroke volume variation, and that again identifies patients who will be responsive to fluid. Again, always keep in mind that these parameters, any patient is responsive to fluid means that you will be giving liberal fluid. It's not that way. Again, your clinical judgment, your vigilant judgment is very important in that condition. This is a pictorial thing of how to perform the tidal volume challenge. Then we have spoken about the trans thoracic echocardiography. That is very helpful. Our ultrasonography, that is again helpful. You can see in this picture that IVC is IVC. You can see that with inspiration, as the with the physiology, you can see that whenever patient inspires, then IVC will be collapsed, and the volume will go to the right atrium. Again, the many of the intensivists, like one other parameter that has been is like we one can use in the clinical practice, like IVC distensibility index. If it is more than 18%, again that will suggest that these patients you can give fluid. Uh, okay, positive pressure ventilation. Then in the normo or hypervolumic patients, IVC will not there will not be the changes in the diameter of the IVC. In the hypovolumic patients or in the septic shock, when the fluid responsiveness is there, this IVC distensibility you can see that. And if it is more than 18%, then definitely you can give fluid in those patients. This is few of the like clinicians, intensivists, they have even used jugular vein distensibility and internal jugular with the Doppler with the Dopplers, and IGV distensibility more than 18% prior to volume change had an 80% sensitivity and 85% specificity. Combining IGV distensibility more than 9.7% and PPV more than 12%. These are the cutoff values. You can predict the fluid responsiveness with a sensitivity of 100% and specificity of 95%. Again, when these two parameters are combined, more accurately you can predict the fluid responsiveness. Now, when I was talking like pulse contour cardiac output monitoring system, you can get these indices directly on that system, on that monitor. You can get all these systems, and these are very helpful in managing the fluid in different types of shock. We have seen in the very first slide that cardiogenic shock is there, then then your distributive shock is there, hypovolumic shock is there, then your obstructive shock is there, then cardiac index. As you can see that cardiac output normalized to body surface area. Okay, this is in between the range of 3 to 5. Low cardiac index, decreased cardiac index like cardiac failure, then hypovolemia or high afterload. Okay, then increased cardiac induction. This is in the hyperdynamic circulation. You get like figure say 7 8 whenever like initially in the sepsis patient where is the distributive shock is there, that is the initial phase. And different other parameters they have been we can see in these advanced monitoring systems. Again, as we discussed that the stroke volume and stroke volume variation, this stroke volume variation we can see on these advanced monitors. It is a percentage change in the stroke volume during respiratory cycle. If it is less than 10, more than 10%, that already we discussed this cutoff value, your patient is fluid responsive. Then if it is less than 10%, no benefit from volume. Okay, this fluid responsiveness and giving the fluid, it is very important aspect in the critical care field. It's just any like you cannot give fluid just directly like that way. It is one of the important pillar for the outcome of the patient, that matters a lot. And your outcome of that patients will all depend on this. Is one of the factor along with other factors like various drugs you are using, then nutrition and everything. Then DP max, maximum rate of pressure rise in the, again this parameter you can see on the advanced cardiac monitors. Decreased DP max, as itself suggests that poor contractility, cardiogenic shock, this will be decreased. Then the increased DP max, again, as with cardiac index or stroke volume variation, hypercontractile states like sepsis or distributive shock, vasodilatory system, it will be increased. Then preload assessment, these are the some indices like global end diastolic. Preload is very important because Frank Starling law also you can see that that preload matters a lot when that excessive push is given, that leads to increase in the cardiac output and that helps in managing the shock. Global end diastolic volume, total volume in all heart chambers at the end diastolic end diastole. Okay, low global end diastolic volume, that will suggest hypovolemia. Then high global end diastolic volume, again this will be overload, just like a cardiogenic shock or pulmonary edema. Then ITBV, this is a intrathoracic blood volume within the heart and pulmonary circulation. This is equal to 1.2 into GDV. It is better than CVP for assessing the preload. Okay. Then ELWI, this is the extravascular lung water index, fluid content in the lung tissue. Again, these few of the figures like cutoff values you have to know directly. You can see those on the monitor. If ELWI is more than 10, this will suggest pulmonary edema, ARDS. Again, in that case, you may not be giving the fluid in that patient. That matters a lot. Then systemic vascular resistance. These monitors like Pico monitors, they can show you this systemic vascular resistance. That is an important factor in maintaining the blood pressure. If it is SVR vasoconstriction, it is increased in the vasoconstriction, shock, hypertension, where in the shock that will be there. Then particularly in the cardiogenic shock, like physiological response is there, this SVR will be on increased side. In the sepsis, like you can see this SVR is decreased. The normal values, like it is in between 1000 to 1500. If it is decreased, like you can see that figure of 500 or something like that, it will be suggestive of, or it will correlate with your clinical diagnosis of sepsis. And then there you need the inotropes. Then there you need to like various drugs like antibiotics will be changing. Then mean arterial pressure, it is the main pressure that perfuses the tissues or organs to maintain. Ultimately, our goal is to keep the perfusion going to the end organ systems. Decreased MAP, that is seen in the shock states, hypoperfusion. We here the 65 mean arterial pressure we take as a figure. We try to maintain above that. Then pulmonary function and overload. This parameter we see already. Extravascular lung water, if it is more than 10, it indicates pulmonary edema. There is one more indications, like this can happen in the pulmonary vascular permeability index. This can happen in sepsis that is leading to ARDS, where say your stroke volume variation is like more than 10, but again like that suggests that you can give the fluid in those patients. But if this like pulmonary vascular permeability index, if it is more than 3, like you can see that ARDS sepsis, then you will be giving fluid with precautions, because as the stroke volume initially like that fluid will be fluid responsiveness would be there, but later on you will have to cut down on that fluid. And if it is less than 3, that this will be particularly seen in the case of cardiogenic shock, pulmonary edema, where the cardiac index will be low. Then your extravascular lung volume will be more, and vascular permeability index will be less than 3. Like this combined use of all these 3-4 parameters, you can very well predict that your patient need fluid or not. key takeaways from this, like stroke volume variation, then global and diastolic volume, intrathoracic blood volume. This is used for the fluid responsiveness. Again, I am repeating some of the lines because these are very important when you practice a critical care and when different kind of shocks that come to you and you have to manage, because that matters, that 1 minute matters, that 1 hour matters, that first day of your management matters. If any mistake is there or if any mistake is there, then that can have very deleterious effect and irreversible changes in your patient's homeostasis can be there. Then cardiac index and stroke volume assess the cardiac function. Then systemic vascular resistance and mean arterial pressure that guides the vasopressor therapy, because all these therapies are very important. Fluid responsive fluid therapy, then your use of the inotropes, like in the when cardiac index is low, cardiogenic shock you are suspecting, then definitely you will be needing dobutamine. Then when like sepsis shock you are dealing with, there is a SVR is on lower side, then you will need the noradrenaline therapy. That matters a lot. Like if ELW extra lung water index that is more, PVPI is low, that suggests cardiogenic edema, pulmonary edema, then you'll be considering diuretics use. But if like ELWI is high, PVPI is also high, that can be sepsis that leading to the leaks, then you may not be using the diuretics in those patients. So various parameters and your clinical judgment, then again monitoring your urine output clinically, then routinely also their capillary fill time, that also we can see clinically. All these matters in managing a critical patients. And this heart is at the center of all the system, and that perfuses the organs and that keeps the homeostasis, and that is very important. This is the final key takeaways I'll give. Septic shock, low SVR, high cardiac index early phase, fluid responsive. If SVV is high, needs vasopressor. Cardiogenic shock, low cardiac index, high SVR, not fluid responsive, needs inotropes and diuretics. ARDS with capillary leak, high ELWI, high PVPI, fluids with caution, avoid diuretics unless overloaded. Okay, these dynamic things you need to keep a watch, and every minute counts to save a life of patient. That always monitor, and you have to have a good team working with you, and they have to be 24/7 on toes, 24/7. They need to be vigilant. This matters, and I today's lectures, today's talk, I wanted to convey that these monitoring systems are there for a better outcome of the patients. But now you can see this is a funny picture. Like if you just rely on the technology, but you cannot, if you do not apply the common sense or that way, here just on the monitor either he is gone or the net is gone. But you have to like thoroughly correlate it with the clinical therapy. That clinical judgment will never replace in any technology, and that your vigilancy will save the lives of patient. Thank you. Thank you very much.
Thank you. Thank you very much, sir.
Thanks a lot for again giving opportunity to talk on this platform, and hope many PG students would be there, and those particularly medicine anesthesia students, they have attended this webinar. This will be helpful to them all. Okay, thank you once again.
Thank you, sir. You have been a constant support and a permanent speaker for Elite CME Academy. Thank you very much, sir. Indeed, it was a very detailed, and all the aspects of critical care were covered in a very short span of time. So thank you very much, sir. I request Dr. Shafi sir to kindly present the memento and certificate to Dr. Yogesh Lakhas sir.
Shafi sir is close to our heart. He is the
Sir, kindly stop
Yes, yes.
sharing your screen.
Okay. just a minute. Uh, okay, yeah, stop. Yeah.
Yes.
Thank you, sir.
Thank you very much, sir, for your excellent talk.
Yes, thank you, sir.
Always unconditional support for us.
Yes, yes. Thank you, sir. You are at the center of our like all academic events that you are arranging, and a lot of congratulations to you, sir, for that. Taking those efforts, and it is all possible just because of your efforts and your whole team's efforts, sir. Yes, sir. Thank you, sir.
Thank you very much,
Yes,
sir.
yes, 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 sir.
So I would now call upon our next speaker, Dr. Mahesh Tande, sir. Sir is a professor in Department of Obstetrics and Gynecology at Indian Institute of Medical Science and Research. He is an extraordinary undergraduate and postgraduate teacher, very thorough with his expertise. Sir is having a clinical experience of more than 20 years, many international and national publications. And one of the reason why apart from academics, sir is involved in this webinar is he is an adventure lover. Sir loves to track, and trekking is very good for your cardiovascular health. So definitely the one who is practicing good cardiovascular health maintenance will teach us how we can practice and how we can inculcate same in our patients. Sir, I'll stop sharing my screen. I request you to kindly share your screen, sir.
Is it visible?
It is in process, sir. It will come.
Yeah.
No, so your PPT is not yet visible, sir. Can you open it once again? Can you click it?
Yeah, already opened it.
Please share the screen once again.
Is it visible now?
No, sir. You have not shared the screen, sir. Your computer screen is visible, sir. You can open your PowerPoint presentation now.
Yeah, I have opened the PowerPoint presentation. Is it visible now?
No, sir. Sir, stop sharing your screen. Open the PowerPoint presentation and minimize it.
Okay.
Yeah.
Is it visible now?
No, sir. Sir, please stop sharing your screen. Yes, sir. It is visible now. Now it is visible, sir. Yeah.
Yeah.
Yes, sir.
So
Yeah,
And
perfect, sir. Perfect.
Yeah. At the outset, I would like to thank organizers for giving me this opportunity to share my thoughts. After this informative talks, I'm going to talk about the cardiovascular health in the pregnancy. So I'll be covering all these things in my talk. So why we need to talk about the cardiovascular health in pregnancy? Though the prevalence of disease is 1 to 4%, but it is the one of the leading cause of maternal morbidity and mortality. It is as high as 20% of pregnancy death in developing or developed countries are occur because of cardiovascular diseases. So common causes, as we know, that rheumatic heart disease, congenital heart disease, cardiomyopathies, arrhythmias, and now we have infections which are going down, but we have coronary artery disease and hypertensions which are coming up. Because we have not many women who are aging, they're planning a pregnancy very late into their lives, reproductive lives, and there is a ultimate need in our country to develop in cardio obstetrics that will take care of a mother who have a cardiovascular issues. So before we go ahead with cardiovascular health, we need to understand some hemodynamic changes that occurs during the pregnancy. That in terms of cardiac output, in terms of heart rate, in terms of systemic vascular resistance, and in terms of blood pressure. So if you see the cardiac output, so cardiac output is not only maximal in the third trimester, but it will start rising from the first trimester itself. As early as fifth week of gestation, the cardiac output will start rising. It will go until 24 to 28 weeks, where it will be maximum, and it will be maximum during the labor. That means any woman who has a cardiac disease, critical disease cardiac, she may be symptomatic at first trimester itself. And someone who has a mild to moderate disease will be more symptomatic during their peak phases like end of second trimester, early third trimester. And some mild disease may be symptomatic during the labor. The change in the cardiac output will take little longer time. Like immediate postpartum is a very high risk period, followed by it will take at least 3 to 6 months to normalize. The blood pressure will start dropping down in initial months till the second trimester, that we call as mid trimester drop. So that mid trimester drop and in the late second trimester, the blood pressure will start rising gradually until the end of pregnancy, which will decline at the end of postpartum period and will normalize between 3 to 6 months postpartum. Heart rate will continue to rise throughout the pregnancy. So a difference of 10 to 20 beats per minute, and it will come down, it will decline in postpartum, will be normalized in 3 to 6 month postpartum. Same is the systemic vascular resistance, which will decline throughout the pregnancy and will increase immediately postpartum and will normalize at the 3 to 6 months postpartum. What is important to note in this that we initially thought that 24 hours post-delivery is immediate postpartum period. Early postpartum period is till 7 days, late postpartum till 6 weeks. Now what we say is extended postpartum period, that is till 3 months. And the later period, because why the cardiovascular complication in pregnancy may occur in these phases. So that's why they need to be monitored throughout the pregnancy and the postpartum period. If you see important change among the cardiovascular is the hematological changes. If you see these graphs like plasma volume and blood volume will keep on increasing. It will start increasing around the 5 weeks of gestation. It will gradually increase to 40-50% of non-pregnant state and it continue to rise. But the maximum change occurs during the labor and postpartum period. Same way, the cardiac output, which is started rising and will keep rising from 24-28 weeks of gestation and then during the labor. This is the postural change that happens in the pregnancy because of gravity uterus. If you see the change in the systolic blood pressure and the diastolic blood pressure because of lateral decubitus position and the supine position, there's a lot of difference in terms of blood pressure change. When you see any woman which is going to compress onto the inferior vena cava, and which will be when the uterus is either dextrorotated or levorotirated, the change which will happen of almost 10 to 15 millimeter of mercury. So pregnancy is complicated by the so many pre-existing conditions. Amongst them is the important cause which is still there in India is rheumatic heart disease, followed by congenital heart disease and defects. We have an abnormal heart rhythms, high blood pressure, which is now a main concern because of aging population. It is important concern. Few structural heart disease, as I already said by Lucas, the cardiomyopathy or peripartum cardiomyopathy and pregnancies with the cardiomyopathy as important. Now this pattern is increasing. Like we have so many women, younger women coming with the coronary artery disease and some vascular diseases. So periods, we need to understand the periods of greatest cardiac risk events is 24 to 28 weeks, early third trimester, during the delivery, and immediate postpartum. So all these phases, a woman with mild to moderate and the critical, they always have a chance of cardiovascular collapse or cardiogenic shock or cardiac failure. These are coming in these gestation like 24, 28 weeks, early third trimester, deliver an immediate postpartum period. So for that, the WHO has stratified the risk, or WHO modified risk scoring system. We have 4 classes of WHO scoring system that you need to understand. Is class 1, there is no identifiable elevated risk. That means absolute mortality will be less than 1%. It's as good as the general population. When we have class 2 and class 3, there's a mildly elevated maternal mortality, but there's moderate elevation in the morbidity. That means mortality can go as high as 5%. But in class 3, the substantially elevated risk in maternal morbidity and mortality. And the morbidity is severely elevated. Class 4 is the extremely elevated risk. That means mortality can go as high as 50%, and there is severe elevation of morbidity. And important to note that in class 4 diseases, pregnancy is contraindicated unless in very special circumstances, anybody will advocate them to have a pregnancy to be continued. So WHO risk scoring, continuing the, so these are the conditions where we categorize them into class 4. Class 4 is like pulmonary hypertension, severe mitral stenosis, vortication of aorta, Marfan's disease with aortic diameter which is more than 45 millimeter, bicuspid aortic wall, LV dysfunction less than 30% ejection fraction, and hypertrophic peripartum cardiomyopathy. These are the conditions where we will not advocate the pregnancy. These are class 4 where the mortality is as high as 50%, and there is class 2 and class 3 are like unrepaired ASD and BSD, tetralogy of Fallot, which is repaired, some arrhythmias, vortication of aorta, which is repaired, is mild LV dysfunction, fundant circulations, systemic RVs, hypertrophic cardiomyopathy, Marfan's with the diameter of less than 50 millimeter, and bicuspid aortic wall. So WHO class 1, these are the conditions where the pregnancy does not pose much of risk. There's mild elevation in the morbidity, like small or mild pulmonary stenosis, small PDA, mild MVP. There's few isolated or ventricular ectopic bits, or this is repaired pulmonary venous drainage system. So these are the high risk conditions. Besides this, what is important is we're going to discuss about NYHA class. So any disease out of these conditions which I previously mentioned, any disease which NIMHA class 3 or 4 symptoms are considered as high risk conditions. Anybody with severe pulmonary hypertension with the septal defects, anyone who has a severe LV outflow obstructions, or a cyanotic heart disease with pulmonary hypertension. Moderate is like systemic right ventricle like TGAs, cyanotic lesion without pulmonary hypertension or Fontan type circulations, or the low risk conditions like ventricular or ASD which are unoperated, PDAs or coarctation of aorta which are repaired. So cardiovascular conditions arising during and after pregnancy is one important is abnormal. That there is a little change in the heart rate in the pregnancy, that is 10 to 20 beats per minute throughout the pregnancy. But there's some chances of abnormal heart rhythm during the pregnancy. There's always a chance of high blood pressure. That means there is always a chance of chronic hypertension which is complicating pregnancy, or There is chances of hypertensive disorder of pregnancy that includes your gestational hypertension, that includes your preeclampsia, that includes your severe non-severe preeclampsia and the eclampsia. Peripartum cardiomyopathy is another entity which will manifest in the late third trimester till the 6 months of postpartum period, and some vascular disease which may complicate the pregnancy. So for risk assessment, there are two scores which have been advocated. One is CARPREG and another is Zahara. It is the first tool that was developed in 2001, and recently it is changed to the CARPREG 2 risk score. Zahara is another risk score which is developed particularly for the women of congenital heart disease. Another score that is ROPAC, that is a Register of Pregnancy and Cardiac Disease, which improved the accuracy of WHO classification of risk scoring by just adding two important factors, atrial fibrillation and signs of heart failure. So if you see CARPREG is nothing but a cardiac disease in pregnancy, it is going to predict you a cardiac complications that will occur in the pregnancy with pre-existing heart disease. They have included these four things, that is previous cardiac event, NYHA class 2 or cyanosis, left heart obstruction or reduced LVF. Based on this, there is a score which has been generated. Every point has given a score of 1. If the score is low, that is 0 point, that none of these four factors are present, the score low risk of complications. That will be the pre-existing cardiac disease, the risk of complications less than 5%. Any one of the point which is present, we are the intermediate risk. That means the risk will go to the 25 to 35%, and the risk score which is high, that is any of these 2 points which are present in the score which is already mentioned, like previous cardiac event, NYHA class 2, heart obstruction, and LVF, which is less than, so they were at high risk. That means they have more than 75% chance of having a complication during their pregnancy. Another score is the Zahara score. The pronunciation for this is very difficult, but it is another score which is risk assessment model used to predict a cardiac event in the pregnancy with congenital heart disease. There are almost 7 factors considered, like history of arrhythmia, NYHA class which is more than 2, cyanosis or saturation less than 90%, systemic dysfunctions, aortic or ventricular outflow obstructions, presence of mechanical wall, and use of anticoagulation before pregnancy. So Zahara score has a scores of 0.2, 0.5, 0.75, 1.25, and 1.5. Based on that, in the same way, if you have a risk score which is low, that is a points of 0.05, the minimal risk of complication. Moderate risk score will has intermediate risk, and the points which are more than 2 points, the high probability of maternal cardiac. So based on these two scores, we can categorize or stratify the risk for the pregnancy. So it is important to note that there are symptoms because of hemodynamic changes in the pregnancy. There is a lot of hemodynamic changes in every system, let it be a cardiovascular, let it be a hematological, let it be a gastrointestinal, every system has changes. So there are few symptoms in the pregnancy that may mimic as cardiac disease. So we need to understand there's one important thing, that is decreased exercise capacity, tiredness, dyspnea, palpitation, lightheadedness, and pre-syndrome. These symptoms can come as early in the pregnancy, and that may mimic as a cardiac disease, but they are not actually. Other way around, any woman who has a critical cardiac disease may present with these symptoms very early into the pregnancy. So you have to differentiate. There are few symptoms which are there in the pregnancy which may mimic like cardiac diseases. The few physical signs they may mimic as a cardiac diseases, like there is little bit of cardiomegaly in the pregnancy. There's palpable RV and PA impulse in the pregnancy. There's loud S1 present in the pregnancy. There's exaggerated splitting of S2. There's missed systolic ejection murmur, and there is mammary murmur or cervical venous hum, which is there in the pregnancy. Before you interpret the investigation in the pregnancy, you need to understand there is a left axis deviation that occurs in the pregnancy. There are STT changes that will occur in the pregnancy. The sinus tachycardia is very common in pregnancy. Eco-unit to be aware of LV-RV change in LV and RV dimensions, L and RA size. There's always an element of small pericardial effusion, and functional TR, PR, MR, and AR are very common in pregnancy. So when to suspect the heart disease, besides the symptoms which I already said, that besides these persistence of any of these symptoms, like decreased exercise capacity, tiredness, dyspnea, palpitation, lightheadedness, pre-syncope. Besides that, if they have a previous history of a cardiac disease, if there's orthopnea and paroxysmal nocturnal dyspnea, there's excessive fatigue, palpitation, which is either associated with sweating or syncope, and the chest pain, where you can suspect the heart disease. When there is a pulse which is low volume, there's a tachycardia, irregular rate of rhythm, when the pulses are unequal, when there's any sign of cardiac failure, any systolic murmur, which is 3/6, or presence of diastolic murmur, will point towards the cardiac disease in pregnancy. So this is the NYHA classification. This is more important in terms of clinical risk stratifications. That is, class 1 is there is no limitation to the physical activity. Class 2 is slight limitation to the physical activity. Class 3 is marked limitation of the physical activity. And class 4, that means she's unable to carry out any physical activity without discomfort. That means she's uncomfortable even at the rest. So these are the conditions where the termination of pregnancy is advisable. One is your Eshing-Morrison syndrome. Second is your Marfan syndrome with aortic involvement, severe pulmonary hypertension, fortification of aortas, symptomatic severe AS or MS, severe left ventricular dysfunction like ejection fraction less than 40%, and metallic prostatic valve with complications. So in terms of preconceptional care, important is that besides routine obstetric preconceptional advices like prenatal supplementation against immunization, few tests like sugars, modification of diet, and the addition of thyroid function testing, adequate exercise tolerance, obstetrician and cardiologist should work together in terms of preconceptional care with the known cardiac disease. They have to prevent unwanted pregnancy and assess the risk associated with the pregnancy. And the decision for continuation or termination will be taken by obstetrician and cardiologist together. In antenatal care, besides your detailed obstetric history, in terms of previous pregnancy event, in terms of previous cardiac event, and the routine obstetric examination, functional status as per NYH is important. Cardiology consultation at the first visit is important. And investigation, we have a routine antenatal investigation that includes your complete blood count, thyroid function test, screening for gestational diabetes mellitus, screening for asymptomatic bacterial, serological testing, thyroid function testing, and the investigations for a fetus, that means ultrasonography. The investigation in terms of cardiac is ECG and the 2D echo. These are the two important investigations at the first visit that needs to be done. So those are with cardiac disease and NYHA class 1 and 2, they can limit their strength exercise. The adequate rest is suggested. Iron, calcium, and vitamin, prenatal vitamin supplementation should be continued. They should be low on salt diet if suggested. Regular cardiac and obstetric consultation at every visit, and identification and treatment of any infections to be done, like hyperthyroidism and infection should be done early. Those with class 3 and class 4 needs to be hospitalized for the pregnancy. There's need for intensive close monitoring. If needed, the cardiac intervention and surgery can be planned. And in some cases, you have to decide on termination of pregnancy. And you have to treat all the factors that are going to precipitate the cardiac risk. Word about interventional cardiac surgical management. The optimal time for any cardiac intervention is second trimester. Balloon volumettomy is a preferred mode of interventions, but if needed, open heart surgery have a little bit of risk if the they perform in the first trimester. There's always high risk of fetal malformation and the fetal loss, and there is always chance of premature labor in third trimester. Coming to the fetal risk, when the pregnancy with a heart disease, the important fetal risk is of congenital heart disease. If you see any woman with congenital heart disease, any mother who has congenital heart disease, in general population, risk of congenital heart disease is 0.4%. That will increase to almost close to 4%. If the disease is autosomal dominant, the risk is as high as 50%. And if the disease which involves to the right outflow or left outflow, the risk increases to 9 to 11% or sometimes 3 to 17%. So all the fetuses with woman with a cardiac diseases, we screen them at a routine antenatal scan, that is a dating scan between 8 to 10 weeks for assessment of gestational age. The nuchal scan, that the genetic scan is done 11 to 13 weeks, where we'll screen for early abnormalities. We screen for preeclampsia because important risk factor in cardiovascular is addition of a hypertensive disorder pregnancy. We screen them at 20 weeks for structural malformations, and at 24 weeks, they need to be screened for a fetal echo for any element of congenital heart disease. Second important risk in mother with the cardiovascular disease is the prematurity. Third is fetal growth restriction. Maternal cyanotic disease, baby may suffer fetal hypoxia. And there is a lot of effects of maternal drugs like teratogenesis, growth restriction, and fetal loss. These are the important fetal risk associated with cardiovascular disease in pregnancy. So mode of delivery is vaginal birth is advocated in the patients who are hemodynamically stable. Cesarean section is indicated only in only cases of aortic dissection, Marfan syndrome with dilated aortic root, hemodynamic instability, and some obstetric indications. Otherwise, vaginal birth is preferred. Intrapartum important is intensive hemodynamic monitoring is must. Admission to the few days before labor, monitoring pulse, blood pressure, and oxygen saturation, and need for oxygen supplementation intrapartum. So careful attention should be made for volume strategization. Fluid should be managed stringently. Assessment of pulmonary basic reps and JVP need to be done. Treatment of arrhythmia should be done, and the epidural analgesia, which is important. Obstetric procedures to cut short the second stage of labor, like forceps or ventouse. Left lateral decubitus is preferred. Management of third stage should be done actively to avoid volume loss. Use of diuretic to avoid the cardiac failure, and the endocarditis prophylaxis as per the protocol. So important care plan for intrapartum is multidisciplinary input that includes your cardiologist and obstetrician and the anesthesiologist. You have to outline the timing, location, and the mode of delivery. You have to identify the monitoring needs. You have to formulate it by early third trimester. It should not be on an emergency basis. So you're going to plan the care by end of before your third trimester ends. And second important in terms of epidural analgesia, because all women will need a pain relief to avoid change in a pulse volume. And the mode of delivery again is a vaginal birth. Only in selected cases, the cesarean delivery is reserved, mostly for obstetric indication, assisted second stage, and the stage 4 conditions like severe pulmonary hypertension, critical left-sided valvular disease, and severe aortopathy. These are the cases where we need a cesarean section for cardiac. In a postpartum, important thing is the risk period for postpartum is your immediate postpartum period. And you need to understand the hemodynamics do not return to the baseline for many days after the delivery that we have initially talked about, like physiological changes, that hemodynamics will not return to the baseline many days after the delivery. And women with intermediate or high risk may require monitoring for at least 72 hours. Lactation should be encouraged unless woman is in failure, and thromboprophylaxis according to the protocol. Contraception is important for all the women who are either planning a pregnancy or who has already given birth, because unwanted pregnancy should be avoided in cardiovascular diseases. So they are type 1, type 2, and type 3. The safest will be the variant method, where they have more failure, but they're safest in terms of cardiovascular disease. A small word about prosthetic valves in a pregnancy. There are two types of valves which are used. Is one is bioprosthetic valves and the mechanical valves. So important in these women is women with a prosthetic valve should be counseled before the conception, avoid the risk to the mother and fetus. They should be counseled in terms of their potential complication like thromboembolism, valve failure, and harm to the fetus. Important thing in terms of mechanical valves is a therapeutic anticoagulation throughout the pregnancy to reduce the risk of thromboembolic event. Bioprosthetic valves usually do not require the anticoagulation, but they have high risk of valve failure. So important in terms of mechanical heart valves is the anticoagulation using a warfarin. Warfarin is a known embryotoxic, and there is warfarin embryopathy. But the skip, you cannot change warfarin unless and until dose is less than 5 milligram per day. We continue to take, let the woman take the warfarin throughout the pregnancy. But if someone is needing a warfarin which is more than 5 milligram per day, what we do to avoid a risk of embryopathy, that once the pregnancy is confirmed, they are shifted to the heparin in the first trimester, and she's put again on the warfarin from 14 weeks to 36 weeks, and then again on the heparin till the delivery. And in postpartum, they are again shifted to the warfarin. So that will help to reduce the risk of thromboembolic event and reducing the risk of warfarin embryopathy. So these patients need to be monitored. These women need to be monitored closely throughout the pregnancy. And if the valve thrombosis occurs during the pregnancy, thrombolysis is the preferred treatment. So important note to that, I would request Lata sir to think about this, because there is a need of a cardio-obstetrics. Cardio-obstetrics is a branch which refers to an approach of maternal care that is based on a teamwork with a specialist from maternal fetal medicine, cardiology, anesthesiology, neurology, nursing, social work, and pharmacy. They have to be together to achieve appropriate outcome for pregnancy and cardiovascular disease. So there is a rule of interprofessional team in the management in cases of class 1, class 2, and class 4. Whether there is contraception counseling, you have to counsel about baseline monitoring of cardiac assessment, pregnancy risk assessment, referral to the OBGYN cardiology care, referral to the tertiary or quaternary care, and the fetal echocardiography, maternal echoes. These are all trimester, each and every trimester we screen them, and the symptom-driven testing. So in conclusion, pre-pregnancy counseling and risk stratification should be done in all women with heart disease. Treatment options should be discussed according to the stage of cardiovascular disease. Successful pregnancy is possible for women with class 1 and class 2 heart disease. Optimal care requires a multidisciplinary team approach. Thank you.
Thank you very much, sir. A very difficult situation for entire family, that the female is having some cardiovascular disorder and two lives are under the risk, and expert faculties have to get involved, and most of the emotional attachment with the pregnant cardiovascular patient is there. So very deep and in detailed talk given by Dr. Mahesh Tandre sir. Thank you very much, sir. I request Dr. Shafi sir to kindly present the memento and certificate to Dr. Mahesh Tandre sir.
Thank you very much, sir, for your excellent talk. Dr. Mahesh Nandade.
Thank you so much, sir.
In obstetrics and gynecology at our institute. And this is first time he is presenting with the Elite CMA Academy. So I welcome him and I'm very thankful that you have given a very excellent talk. Thank you very much, sir.
Thank you, sir.
Thank you, sir.
Thank you.
So, moving forward to our next speaker. Madam is a very dynamic lady, and all of us know her, maybe met her. So, Dr. Trupti Borulkar, Madam, she is MBBS DCH MD, and a lot of PGs and postgraduate specialist attached to Madam. She is been working in the field with over 25 years of experience in pediatric and child adolescent counselor. Her interest areas are centered on emotional, psychological, and mental well-being of children. Alongside clinical practice, she is actively engaged in various social initiatives, conducting workshops, seminar, conferences, and lectures that address pressing health and community issues focused on women and children. With her literature expertise, many articles are aimed at raising awareness in educating the public, and important healthcare topics are published in various regional, national, and international forums. She has 5 to 6 literature books and 4 medical books on her name. In healthcare administration, she has taken a key leadership role managing the operations of hospitals and medical colleges, ensuring the heights standards of patient care and health education. In the field of medical education since 2018, she has been actively involved in curriculum, student welfare, research activities. She has played a significant administrative role in different medical colleges. 3 of them, I have also seen Madam working very efficiently and very systematically. Madam have a nature of doing things. She is currently associate professor and pediatric counselor at Symbiosis Medical College for Women in Pune. She is leading her career with focus on improvising health and healthcare system, ensuring quality care, and fostering the next generation of medical professionals. In our language, we now call them as Indian medical graduates. Indian Association of Medical Education West Zone have appointed Madam as secretary, and her thesis topic for MD was yoga and its effect on depression, anxiety, and stress. And hence, the topic suits to the profile of Madam, that she will speak on one of the upcoming, field in well-being, that is yoga and pranayam. And I'll share the screen for Madam, and she will be talking. So whenever you are ready, Madam, we'll start.
Yeah, sure. Thank you, Dr. Zubair, for kind introduction.
Thank you.
More. And thank you, Dr. Shafi sir, and the whole team for giving me opportunity to present in front of the August gathering. So today we are dealing with heart harmony. Till now we have seen the pathophysiology, therapeutics, even special conditions like pregnancy and CVD. So now we will be talking on a preventive aspect. So being with pediatric background, I also done my MD physiology. So now I am talking as a physiology. So pathophysiology for every diseases is there. And we want to break that and come into physiological basis so that it becomes a normal thing for each and every person. And so that though they won't deal with the diseases in their future life. So lifestyle modification is an upcoming branch in the physiology. So today we will see that part of the physiology related with cardiovascular diseases. So cardiovascular diseases are the leading causes of global mortality. And WHO is giving emphasis on SDG for reducing one-third deaths by NCDs, that is non-communicable diseases, by 2030. So CVDs are a leading cause of global mortality. Hypertension, stress, poor lifestyle choices contribute significantly to heart disease. So hypertension is a major risk factor for heart disease. Stress leads to unhealthy coping styles and unhealthy coping mechanisms. So they disturb sleep patterns, smoking, and overeating, and then they lead into diseases. So poor lifestyle choices again play a critical role in prevention. So a healthy diet, a healthy regular exercise habit, or stress management again helps to reduce the risk of heart disease. Yoga, pranayama, and meditation are effective evidence-based approaches to maintain cardiovascular health. Yoga has shown to improve arterial flexibility and circulation, reduces blood pressure and resting heart rate, and aid in weight management. Pranayama has also shown to enhance the heart rate variability, lower blood pressure, improve oxygen utilization, and reduce inflammation and oxidative stress. Meditation has been shown to lower cortisol and adrenal levels, improve emotional well-being and resilience, reduces inflammatory markers like CRP, and enhance mindful eating and healthy choices. So we will go one by one. So what are the benefits of yoga in cardiovascular health? So yoga plays a major role in cardiovascular health or stability, we can say. So it reduces the stress and anxiety. It reduces the stress by keeping your mind little calm and cool, and you can face the daily challenges of life, stressful conditions in a very good way. So what is the role of yoga? It reduces stress and anxiety. It reduces blood pressure, so lowers the blood pressure. So regular yoga practices has been shown to lower the blood pressure and improve cardiovascular functions. So improves lipid profiles. Yoga helps to reduce total cholesterol and triglycerides, and while increasing the HDL, that is good cholesterol. It enhances cardiovascular function. Yoga improves cardiovascular function by increasing cardiac output, reducing systemic vascular resistance, and improving vasodilatation. It reduces inflammation. It has anti-inflammatory effect, which can help reduce inflammation in cardiovascular system. Yoga also has neuroprotective mechanisms. This is not related with CVD, but again, when the neurological well-being is there, patient is usually calm, deals with stresses and other routine things of life very carefully and maturely, and overall well-being is added to them. The neuroplasticity effect or improvement in the cognitive function also aids the preventive aspect of managing CVDs. On molecular basis, again, yoga helps in some way. So activation of AMPK, that is AMP activated protein kinase, which plays a key role in regulating energy metabolism and reducing inflammation at cellular level. So increased expression of antioxidant enzymes is also there. So yoga causes expression of antioxidant enzymes such as superoxide dismutase and glutathione peroxidase. Then again, reduced expression of pro and inflammatory genes, that is like TNF alpha and IL-6. So overall, there is some effect, good effect, we can say, from the yoga. If you are doing anyone is doing yoga regularly, they will have benefits. So physical health, it improves arterial flexibility and circulation. It reduces blood pressure and resting heart rate. It aids in weight management. Mental health, if we consider, by reducing stress, then cortisol levels, and enhancing mental well-being, emotional well-being, and resilience. Yoga helps. So the key asanas like Tadasana, Viparit Karni, Ardha Matsyasana, or Shavasana, or anything. These are specific things overall improves specific set of muscle like core muscle, lower body muscle yogas are there. Then there is variations in the yoga like power yoga where you sustain that position for more than 1 minute. So overall yoga doing is actually like weight bearing exercises of taking weight as whole body of one's own body. So that is the main thing. So yoga is equivalent like to doing exercise. If you do regularly yoga for say about specific time with power yoga, that means the position you are holding the end position for a specific time, it will give you result like your gym exercises like cardio exercises and all that. Then we will come to pranayam. So what do you mean by pranayam? It's a controlled breathing mechanism. So what are the control breathing? So you consciously do, you are aware of your breathing techniques. So you do some specific counts like anulom vilom, like breathing from one nostril and inhalation from one nostril and the exhalation from other nostril. Or it is a guided, or it is counted, we can say. The pranayam is like that, and pranayam has very good role in calming your mental well-being, or your calming down your stress levels and overall well-being at cellular level. So the oxygenation is and other things are really good at the tissue level, and overall effect of pranayam is really good when we consider art is a inner well-being. So what it does, it does help regulate the breathing patterns, which again helps to reduce the stress and anxiety. It also lowers the blood pressure and improves the cardiovascular function. Then it improves the respiratory function. Mainly, it helps the oxygenation, and the whole body oxygenation is good when you do regular pranayama. It reduces anxiety and stress by activating parasympathetic nervous systems, reduces the systemic vascular resistance, and increases the cardiac output, which will lead to more or improved cardiovascular function. So what are the pranayama methods, or what is the pranayama? It is actually a controlled breathing technique which helps to enhance the HRV. What do you mean by HRV? When there is a time between the two heartbeats is different. So when it is more regular, it is not responding to your day-to-day emotional ups and downs, emotional stress, level stress, or any physical stress. It adds to your cardiac well-being. So it reduces the blood pressure and oxygen, improves the oxygen utilization, reduces inflammation and oxidative stress. So overall, it regulates the autonomic nervous function system very well, and the whole autonomic nervous system function is done at a regular and well-fashioned manner, or we can say on a physiological manner. So the popular techniques are anulom vilom, that is alternate nostril breathing. So one has to take the inhalation from one nostril, say left nostril, and then you have to exhale through right nostril. Brahmari is a hummingbird. You have to close your ears and then just make a sound like a humming bee, and this will help you in calming down, in getting more oxygen, and overall the well-being. So then what do you mean by meditation? It's again concentrating on one thought, or maybe sometimes it is said that thoughtless, that actually that position is not attended by a regular person. But when you do over the years and you are master of that, you can achieve that state, meditative state. But simply keeping you away from the problems of your life or day to day hustle bustle, day to day hurry worry, it is a meditative state. So simply listening to soothing or calming music, walking into garden, or listening to bird chirping. See, such things we can call it as, when you are mindfully doing it is a meditative state. It again lowers the cortisol and adrenal levels, which will again help to cardiovascular good health. Then emotional well-being and resilience, it again improves. So these words are repeated for yoga, meditation, and pranayam. But overall, the cumulative effect is that it reduces the inflammatory markers and enhances mindful eating and healthy habits. So mindful eating is really a need of the today's everybody. I think not today's generation, we can see everybody is really into hurry. So we eat while watching some notifications on your mobile, or talking with some people, or we go for dining out and all that, and everywhere where there is some hustle bustle and some gadbada, we can say. And we are not eating a simple diet, like simple regular meals on a mindful level. So the chewing activity, then everybody knows carbohydrate digestion starts at mouth, and everybody has to chew for 32 times. So what we have learned in our childhood, but nobody is following that. So simple techniques we are forgetting to improve or to keep our health in at the optimum level. So such things, even they look like minor things, simple things, they have long term effect on our health. And if we want our health in a good way, especially we doctors, we are not aware about our problems. We are telling patients, we are telling our students that we have to do like this and this and that, but we are not aware about our well-being. So we have to be good at managing our health, and then we have to express our concerns towards our patients or towards students. So sage on the stage is not the right word for today's teachers or today's doctors, because we have to tell the students and the patients that everyone including us, we must promote the preventive aspect of any disease, not only cardiovascular disease. So meditation is again very important. So what is the holistic preventive models? So lifestyle medicine is part of physiology or part of any medicine pathy, which is recognized by organizations like American Heart Association and many other like WHO and any national, international associations. So personalized protocols should be properly given to patients, like depending upon genomics and metabolics. Tailored yoga practices, tailored food or diet, tailored exercise for meditation and all that should be advised. Community initiatives, now yoga day is celebrated since few years, but community initiatives should be on a more level, or that should be a more activity for that. Then next. So the common mechanism behind all this is yoga, pranayam, or meditation. It reduces the sympathetic activity and overall reduces the blood pressure, then cardiovascular stress, then increased parasympathetic activity will lead or will promote the relaxation and the again reducing the cardiovascular stress, reduced inflammation. That is again a main point, that it reduces the inflammation. So overall effect is really good for the cardiovascular system. And it again in preventive cardiology, we also say the reduced inflammatory effect will be blocking the onset of cancers. So it is again related with that. So by improving your physical health, mental health, and other systemic health, the pranayam yoga and meditation overall gives good optimum health, which will be helpful for tackling not only CVDs but overall like cancers and any other NCDs. It will be again a helpful thing. So what are the recommendations we can say? So practice yoga and pranayama meditation regularly. That is the main thing. So how we can do with some future involvement, like mobile health. Nowadays there are so many YouTube channels, so many apps are there for yoga, pranayama, meditation. But one has to be concerned about own health and should take accountability of own well-being and should be enrolled for these classes and do it regularly. There are so many trials are going for long-term cardiovascular benefits of yoga, pranayam, and all that. So it is a scientifically proven. It is a research method. Research has been done on different methodology using, and it is proved that the yoga, meditation, and pranayam are helpful. So telemedicine integration we can do for remote cardiac patients, like in cardiac rehabilitations. So virtual programs of yoga, meditation, and pranayam will be helpful. So now the focus should be on the preventive aspect, and yoga, meditation, and pranayam are really good for the preventive aspect of CVDs. So the recommendations like regularly doing yoga, pranayam, and meditation is important. But what we can do in conclusion is integrate yoga, pranayam, and meditation in your daily life. Advise your patients to simple tricks like putting some yoga postures or even 12 stages of Surya Namaskar posters in your OPD when the patient is in wetting period. They can watch. You can keep some pamphlets or informative flyers and all that in the OPD. You can run a PPT or any scrolling thing on TV or on screen in your OPD, so that the patient, not only patient but relatives, will be also get sensitized and maybe they are aware. So human tendency is sometimes we know everything but we forget to do, or we forget to do regularly. So we have to do it regularly, and we have to focus on our optimum health, good health. And when we are in good health, we will tell our patients confidently. So my take on this is you can't pour from an empty cup. So you have to be aware of your own health. You have to incorporate such things into your life which are beneficial to your health, and then you can confidently tell patients, students, or our relatives or to community that these things are really good and you should be able to do that. So practicing 15 to 30 minutes daily of yoga, pranayam, meditation is really good. Considering everybody is full packed over the day, we can do it in the early morning or we can do in the evening, wherever we get time. But we have to make it that we are doing regularly on that. Then combined with a balanced diet and regular other exercise for optimum heart health. It's not that only yoga, meditation, and pranayam will help. So the overall good effect will occur when, along with that, the balanced diet, the recommended therapeutics, and regular exercise, and overall how we respond to our life. Everybody's life, there is some ups and downs are going on, or some or other way stress is there. So we have to learn to deal with this, and the yoga, pranayam, and meditation are the powerful techniques to deal with this stress. So thank you once again. Dr. Zubair.
Yes, thank you very much, madam.
Thank you.
Yeah. So, a nutshell of that is we have to make modifications in our life so that it can get influenced on the patients, our patients, and as madam already mentioned, our students and all. So thank you very much, madam, for your wonderful talk. I would call Dr. Shafi sir for presenting a memento and token of certificate to Trupti Borolkar, madam.
Thank you very much, madam, for your excellent talk and your unconditional support for our webinar also. And in future also, we are likely to have the collaboration for our forthcoming webinar on good clinical practices and ethics, course in ethics. Thank you, ma'am.
Uh, due to uh, due to some unavoidable reasons, Dr. Tuba Madam could not get in touch with us. So I would like to call Dr. Shafi sir, Director of Elite Education and Welfare Society, to kindly present the vote of thanks and call the session to be over.
So we have come to an end of today's webinar that was on heart matters, a holistic approach to management of cardiovascular diseases. I'm very thankful to all the delegates for registering this and all other people who have helped us directly or indirectly for the organization of this webinar. Elite Education and Welfare Society Aurangabad is organizing such academic activities regularly, which are accredited by Maharashtra Medical Council. So, lastly, I would like to thank all the delegates for registering. I request all of you, please spread a word about Elite Education and Welfare Society and its academic programs to your friends so that in future they can register and get the MMC points. And also, we are having such a nice academic activity so that this will be helpful everybody. So in future also, we are planning to have many more activities like this. So now we have come to end of this webinar. I am very thankful to my team, Dr. Zubair Khazi. Since morning, you are seeing him. He is taking a lot of efforts to organize in a timely manner. And Dr. Jawad Hashmi, he is the professor in Department of Community Medicine at JII's IMSR Badnapur Jalna. I am thankful to these two young guys for helping and organizing such a beautiful webinar. Then we are very thankful to our college, JIIU's Indian Institute of Medical Science and Research, Badnapur Jalna. We are also thankful to the today's observer, Dr. Ashwamed Jagtap sir from Jalna. We are thankful to our dean sir, our chairman, our CEO, Dr. Ilyas Bemas sir. They are always supportive and they provide us unconditional support and they encourage to organize. I am also very thankful to all the speakers. They have given very excellent talk today. It was like an academic feast for us. I'm very thankful to them that whenever we ask them to be a faculty for our webinar, our program, they are always ready. Webinar will get the points and will get the certificates. Our group of Elite Education and Welfare Society WhatsApp group. Please don't of Elite Education and Welfare Society WhatsApp group. Please don't leave it because time to time we put the instructions. Now tomorrow we will finalize the list of all delegates which we are going to submit to Maharashtra Medical Council. Please check your name in that and certificate will be issued to those who have filled the Google form and this list will be sent to the Maharashtra Medical Council after taking the signature of MMC observer and at least 15 days time will be required for the credit points to get updated in your account on Maharashtra Medical Council website. So please be patient. And one more thing I like to request you people that when we put the list of participants in the group, please check your name. We are getting message after 15 days, 1 month, 2 months, 6 months that sir, I didn't get the certificate, sir, I didn't get the points. So that is your responsibility. Our work is up to 15 days only. So within 15 days, within 3 days only, actually, we submit the names to the Maharashtra Medical Council, and whatever name we get on Google Form is compulsory for the registration of the webinar, so that we get the information, your information in the form of name and registration number, so that we submit this list to the Maharashtra Medical Council. So within 3 days, we will put the list of all the delegates who have registered for this webinar in the group. You have to verify your name. If your name is missing, you can message personally to me. We will include your name in the list, and please don't leave the group. And when we put the folder for certificates, you should find your certificate and download it, because after some time it may or it may not be available. So thank you very much once again. Now I declare that this webinar is over. Thank you. Have a good day.